For the record, my name is Ricardo Royal, the District City Councilor. I'm the chair of the Boston City Council Committee on Public Health. I'm joined by my colleagues, Juliet Mejia, Michelle Wu, Ed Flynn, Kenzie Bach, Andrea Campbell. As more come in, I'll make sure I also intro them. This public hearing is being recorded and live streamed at boston.gov at City Council TV. So that's boston.gov, City Council TV. The committee will be taking public testimony at the end of the hearing. Those giving public testimony will log into a separate public testimony Zoom meeting through the link provided. Please email Shane Pack, that's shane.pac@boston.gov for that link. Please note, you will not be able to watch the hearing through this link. Please watch the hearing through boston.gov City Council TV until it is your time to speak. Public testimony will be called on a first come, first served basis. For public testimony, you'll be muted until it is your time to speak. We are asking for all comments to be no more than 2 minutes and to adhere to the same guidelines for decorum as in the chamber. Please keep your comments appropriate and germane to the docket. If you're unable to access the Zoom meeting, you may submit written testimony to ccc.health@boston.gov. Today's hearing is on docket number 0458, order for a hearing to evaluate the city of Boston's preparedness for the coronavirus strain COVID-19. As invited panelists, we have Mark Lipsitch from the Harvard Chan School of Public Health, Martha Sheridan from the Greater Boston Convention and Visitors Bureau, Sam Scarpino from the Northeastern University Emergent Epidemics Lab, Christelle Murrieta from 32BJ SEIU, Peter Antonellis will be representing the Suffolk County Sheriff's Office. Paul Landrigan is a professor and director of the Global Public Health Program and Global Pollution Observatory at Boston College. He has a background of working with CDC. We have nurses Peg Conlin from Kearney Hospital, Mary Havlicek Kornakia of Tufts Medical Center, Ellen McInnes of St. Elizabeth's. We will also, hopefully, depending on folks' schedules, have Dr. Josh Barokas from BMC. He's the coordinator of their efforts to support vulnerable populations during the COVID-19 epidemic. And then if they also, if their schedules permit, Bob Luz and Steve Clark, President, CEO, and Director of Government Relations for the Mass Restaurant Association. So I want to thank everybody for being here. This is obviously a first, I think, for the council to do an online hearing. So please bear with us as we do this. I just want to sort of give the ground rules. Normally, we would do this as a panel or as in 3 folks at a table or however many, and then we would ask questions of the group. For the sake of ease, since there's so many cameras, since there's so many folks trying to make sure they know what's happening, what I'm going to do is I'm going to call on each guest, allow them to have their say, and then we can do a round of questions from the counselors. I'll give 5 minutes to each counselor for questions. We're gonna waive our openings. And so, hold on 1 second while I figure this out. Carrie, if you can hear me, Counselor Asabi George is trying to get in. If you can let Counselor Asabi George in. Okay, and is Mark Lipsitch, I see you here. If you can unmute Mark Lipsitch, Carrie.
Hello,
Good
can you hear me?
afternoon, Mark. Yes, I can. Thank you for being here. I'm going to give the floor to you. I believe you have a presentation you'd like to give. If you can share your screen and show it that way.
I do. I think it's about 10 or 12 minutes. Is that appropriate?
That's appropriate. And then what I'll do is after Mark Lipsitch goes, I'll open the floor to questions by each counselor. Unfortunately, due to the format, normally that would be in the order that counselors arrived. Due to this format, I'm just going to go down the list and give every counselor a chance. If I put my finger up, it means you have 1 minute left. I'm going to have a timer going for the 5 minutes, and hopefully that works for everybody. If I could just get a thumbs up if folks can see what's on the screen right now, the COVID-19, where are we? Fantastic. Okay, please proceed.
Okay. Sorry, I need to. Okay, thank you for this opportunity.
Mark, before you go, do you mind just introducing yourself a little bit?
Yeah, thank you for this opportunity to be here. I'm Mark Lipsitch. I've lived in Boston now for just over 20 years and worked at the Harvard Chan School of Public Health, where I'm now the director of the Center for Communicable Disease Dynamics and a professor of epidemiology. Our group of several dozen people have been working on COVID-19 since January when it when it became obvious that it was a problem. We're doing a lot of science, a lot of trying to communicate and inform policymakers and decision makers on a number of topics. So it's a pleasure to be here. And I'm going to just briefly tell you where I think we are. I apologize for the quality of these slides. I have literally had no time in the last, as long as I can remember. So I put them together mostly in the last 6 minutes while I was waiting to get started. So apologies in advance, but I hope they are clear enough. So a few data, and some of these are updated and some of them are not. As you know, this infection started in China a few months ago with a coronavirus related to the SARS virus, but quite different biologically. Spread from Wuhan to China to the rest of the world. These case and death data are from I didn't get to update them. They were from when thought I was speaking to you a week ago. The next line, which is that there are 400 deaths in the United States and over 33,000 cases reported, is based on today's data from the CDC. And we estimate that there are probably 10 or 50 or maybe more times that many cases because testing has been so limited in the United States. And so every time you see a number, think of that as a number of reports limited by testing rather than a necessarily true statement of the size of the issue. Because of the complications in trying to estimate how many cases there are, one of the real challenges that I and many others have written about is figuring out just how lethal this virus is. We think that for symptomatic cases, the risk of dying is around 1% to 2%, which is quite high, 10 to 20 times more than seasonal flu, for example. What we don't know is how many asymptomatic or very mild cases there are underneath that surface of the people that we see. We hope there are a lot, in the sense that means that we are that the overall risk of dying per infection is low, but we don't really know at this point. It is not equally lethal for everyone. It's clearly much worse for people who are in older age groups and who have certain pre-existing conditions. By now, you've all seen this notion of flattening the curve, which really means trying to take the outbreak that will be sharply peaked and slow it down in order to reduce the size of the peak and maintain healthcare ability to cope, and also to reduce the total number of cases. So the reason we're trying to do this is that overall, if we can flatten things, fewer people will get infected. It's also better to get it later. We will have more information about what treatments can be effective. If there are any specific antiviral treatments, those will be known better in the future. So if you had a choice, you would want to get it later, not now. And then the most important, in some sense, is that the peak demand is less on healthcare. And the goal of all these flattening the curve interventions is really to try to preserve our ability of our hospitals and especially our intensive care units to deal with the load of severe cases. Still a small minority of all cases, but because it's quite transmissible and because everybody appears to be susceptible to infection, that's still enough to overload the system in some places. We're seeing, and I'll talk a little bit more about that in a minute, we're seeing as of this morning that restrictions have become even tighter in Massachusetts with a stay-at-home advisory and a closure of non-essential businesses. And as the Public Health Committee, you guys are, of course, most directly involved in the public health aspects of this, but it is obvious, and I feel obliged to say this as a public health person, that in trying to protect public health, we are doing damage to many aspects of people's lives. And it's a balancing act for decision makers like yourselves to try to find ways to protect our healthcare system and reduce the direct damage that this epidemic does, while also trying to reduce the indirect damage that our control measures do. And it really is it's a balancing act. But at the moment, I think balance is not really what we need. We really do need to slow things down as much as possible, while then trying to mitigate the consequences of doing that. These are some pictures from a week ago where after the president increased travel restrictions, a consequence that should have been anticipated but was not desired was extreme crowding in airports, and some of the governmental restrictions on public gatherings and on closing places resulted from pictures like these from the bars, where people were really just not getting the message about voluntary social distancing. You've all heard about social distancing and what it means. It really means keeping people from being in close physical contact, or very close proximity where they can cough and sneeze on one another. It also, there are also other interventions, and it's important to remember these because some of them are actually a lot less damaging than social distancing. For example, improving ventilation and humidification of buildings. And my colleague at the School of Public Health, Joe Allen, wrote an article describing some of those in the New York Times, which is listed here. Fixing the incentive for people to be to come to work sick. There are still healthcare settings, or there were as of a week or two ago, where hourly workers had the incentive to come to work sick because otherwise they would lose pay. That's not good anywhere, but especially in a healthcare setting. Schools have now been closed, working from home where possible, which we're all doing. It's hard to say anything nice about the federal response, except that there's one nice thing you can say, which is that there are some spectacular professionals who are trying their best, but are being, for whatever reason, not allowed to take the lead in this response. So the CDC's information, I think anything you hear from them is likely to be true, but it's also very limited and been very confusing to many, and some of you probably have seen that. The states and local infrastructure is going to save us to the extent good things happen. It's going to be very much thanks to our city and state because of the absence of federal leadership. This is a graph from a study that we have recently completed, led by Ruan Lee in our department, and with colleagues at Johns Hopkins. And this is really the flattening, this is the sort of data behind flattening the curve. This is Wuhan, China, where the epidemic started. On January 23rd, they closed the city with a really strong lockdown. And what you see is growing demand over the next several weeks for critically ill people. So these are people who would need intensive care. And if you look at a per capita basis, the highest day of demand in Wuhan would have filled every ICU bed in the United States on a per capita basis. Obviously, there are not that many beds in Wuhan, but if you scaled it up to the US population, that level of illness in the population was enough to fill every ICU bed, and only a third of those beds are free at any given time. So that is a situation that is truly an overloading of the healthcare system. And what's important about this is that the crackdown was on January 23rd. The peak was right around February 23rd. So one of the things that's hard to sort of understand when you're not in the midst of the crisis is that people take a long time to get sick enough to need intensive care. So if you could stop all transmission at this point, you would still have several weeks of growing demand for hospital and intensive care resources. And that's really the reason why all of these measures that we're taking at a time where it's not quite yet a crisis are really called for, and indeed could be, you could argue, should have been done sooner, because we really need a 3-week, we should be worrying about how bad it will be in 3 weeks in making our policy now, which of course we don't know, but we do know it will be worse because this is a growing epidemic. The unfortunate problem is that we have, it's going to be a long haul if we do control it, because if we spread out the demand for hospital beds and critical care, that means that we have a quite long period of social distancing, maybe on and off, and we could talk about that later, but it's a long period when we haven't built up enough immunity in the population through infecting people to be able to let off, because once we do let off, we expect more cases. One thing I will say is that we don't know if there is a large iceberg underneath the tip of the iceberg where people are getting infected and they're so mild that we don't know. And so there is a little bit of hope that there's more immunity in the population than we know about. And that's from people that are just never tested. So it's possible that this is an overly bleak conclusion, but based on current understandings in which maybe a third to a half of all people are asymptomatic, this is what we think would happen. So we need a lot of things. We need, most intensely, we need personal protective equipment, including masks, testing supplies, ventilators, and beds. Other municipalities are already beginning to build new hospitals and convert or convert outpatient facilities. We need lots of other things, but those are the sort of things that are in your jurisdiction. To end on a more positive note, Boston is, as you're well aware, one of the world centers for biomedical innovation and for public health as well. We have 2 excellent schools of public health, and we have enormous resources of many kinds. This is the picture of the Boston Consortium for Pathogen Readiness that got together at Harvard Medical School, but including people from around the city a few weeks ago. And virtually all of these people are really hard at work trying to, with their labs, which means there's another 10 or 20 people behind each of these people, trying to make this response work. And then one part of that, one specific part that's really critical is being led by the Broad Institute of Harvard and MIT, which part of the reason I couldn't make any slides this weekend was that I was spending the entire time almost working with a very talented team of 2 or 3 dozen people led by the Broad Institute to try to build up a testing infrastructure for Massachusetts. They are creating the facility to do testing on an unprecedented scale. And then the sort of discussions that we all were having over the weekend were to try to make testing as effective and valuable as possible to the public health response. And it is absolutely central. I could go on and on and on, but I think I'll stop there and be very happy to answer questions. You're muted.
Sorry about that. So thank you so much. Appreciate it. There's gonna be some bumps as we do this first online hearing. But I'm gonna now open up the floor. I'll save questions from my side for last. I'll open it up to the floor now. very briefly, actually, because I can see everybody who has video. I see Liz Braden doesn't have video, and Jared Campbell doesn't have video, Kim Janey doesn't have video, so I'll get to you all in a second. But people on video, please raise a finger if you want to ask a question. I'm going to start with Councilor O'Malley. We can unmute Matt O'Malley.
Thank you, Mr. Chairman, and Dr. Lipsitch, thank you so much for that overview. And really, obviously, it goes without saying, we appreciate your incredible work, and this is beyond terrifying, but I feel hopeful that we've got some of the best and brightest working on this. Also wanted to thank my colleagues for their great partnership, as well as Mayor Walsh. He's been working tremendously with us to make sure we can get as much information out. One of the reasons why I called for this hearing 2 weeks ago, which seems now like it was 2 years ago, was to get as much information as we can out. Obviously, things are changing daily. So I guess, Dr. Lipsitch, can you talk a little bit about the announcement this morning? You referred to it in the PowerPoint that Governor Baker has put. Is that enough? I think all of my colleagues and I want to do is everything we can to address this as quickly and efficiently, recognizing that this is going to take as strong and quick actions now, looking at what some other cities have, what other countries have done. So can you talk a little bit about Governor Baker's announcement this morning, and just in your opinion, recognizing things will change, if there's more we should be doing or ways that we can really live up to that well? Thank you. I'm going to mute myself now.
Sure. I had only time to read the headline, which was pointed out to me by a Globe reporter on a previous call. So I don't know all the details, but it does seem like this is this is close to the maximum of what we can do to create social distancing. And I'm sorry, I just don't have a informed opinion about it because I haven't had time. But again, to reiterate, the goals are to keep people from being in close proximity where they can transmit, especially in underventilated and dry places. One thing I really hope is that these measures do not extend to closing outdoor areas. If there's some kind of intense crowding problem, that may be one thing, but outdoors is much safer in terms of transmission. You don't want to be hugging somebody outdoors any more than indoors, but you can social distance much better outdoors because there's ultraviolet light, which kills the virus, and there's much better ventilation. So for everybody's mental health and physical well-being, I think that's an important piece to try to avoid. In terms of more stringent measures, it's 2 weeks and we'll see where we get to, but I'm not sure what more can be done at this stage. But I guess I need to read a little bit more about what's been done.
No, I completely understood. Can you talk a little bit about, there seems to be some, and again, it's evolving, so we're learning this, but can this virus be picked up while you're walking outside? I understand the need for social distancing. We've all been banging that drum, obviously, and we'll continue to do so. But is this airborne? Can this live on clothes? I know it can live on surfaces for a number of days. Can you talk a little bit about that?
Yeah, I mean, I think it's really hard to know how to interpret the laboratory data in terms of the risk. I mean, the fact that it can live on surfaces for some days means that there's not zero risk from a doorknob and all those things, and you should be washing frequently touched surfaces as much as you're able, and washing hands, because it's the doorknob to the hand to the face that does it. And as I've just demonstrated, I'm not any good at avoiding touching my face, and most of us aren't. The question about airborne, I mean, a large fraction, maybe not all, but a large fraction of the transmission really is from close contact, from coughing on someone and having the droplet land on them, sort of propelled by you, not from someone was in a room half an hour ago and the air is contaminated. There probably is a tiny bit of, even a little bit of real airborne transmission, but if you're out of doors, that's much less likely just because the air is moving around and your air is not as much shared with the next person as it would be in a still indoor room. So I think if the question is there any risk from being 2 feet from someone outdoors? Yes, and 3 and 4 and 5 and 6 feet would be much better. But the getting to 0 is not the issue. It's really just trying to keep it as low as possible.
Great. And then my final question is, there've been some conflicting data sets. Obviously, it's so new that we may not know, but can you talk a little bit about the impact on pregnant women? I know that the UK has had that as a higher risk a category I don't know that we have yet in the United States, but just if you know anything on that, that'll be my questions for this round. Thank you.
Yeah, I have not followed that aspect. I think everybody's kind of specializing in what they can manage from the fire hose, and that's not the part that I've followed. It is true that many viruses are more dangerous if you're pregnant, and I would follow the UK government's guidance because they're sensible.
So thank you, Councilor O'Malley, for your questions, and all my colleagues for your participation. So some folks, just a heads up, some folks have there's a Zoom app feature that allows you to essentially raise your hand. And so several folks have done that. I'm going to go through that. Everybody will have a chance. And I'm going to go now to Councilor Wu. If you can unmute Councilor Wu, Carrie.
Thank you, Mr. Chair, and thank you, Professor. So appreciate you sharing even more of your time with us amid everything that's going on. Could you just talk a little bit more about timing? I mean, I think the big question for everyone is the uncertainty of how long this will, quote unquote, last. And I know I've heard you speak historically about how historically there have been multiple peaks and not just one that we have to get through, but when you lift the measures, it could come back. When will we have a better idea of how long we might be looking at, and what are the factors that you would look to? Is it going to be about monitoring actual hospitalization rates? Is it going to be about when the vaccine is developed? I mean, so if we were to say go a month from now, would we have a better idea of how long these measures should be in place? What are the factors you'd consider?
Yeah, thanks. That's a great question. And it's a lot of factors. And probably there are some that we haven't even realized yet because we're still learning so much. But I think one thing that will be important is to watch what happens in China as they lift their social distancing. China, other than Wuhan, China put their social distancing measures very intensely in place at a considerably earlier stage than we are in Massachusetts and than most of the US is, probably all of the US is. They had just recently had it introduced and had a handful of cases, and that's not true of Massachusetts. So they had those measures on for 6 to 8 weeks, and they're beginning to lift them now. Or some of them maybe were beginning to lift them a few weeks ago. So I think we'll get a better sense from them of what that looks like and whether new cases begin to appear. It's going to take a while because mild cases are easy to miss, but they will be a harbinger. So I think that will give us some clue about sort of how long and how intense social distancing has to be. A second piece is as we begin to do serologic testing, which means testing people's either saliva or blood to see if they have antibodies, we'll begin to get a sense of whether there's a large group of people who got infected that we didn't know about. If the answer to that is yes, then that will be very good news for our ability to perhaps let up on the social distancing, because it means that there's more immunity in the population. We don't really understand the nature of immunity, but that will be another parallel stream. So I think those are two questions that we'll be watching for. And then the other thing to say is that hospitalization is also a lagging indicator of new cases. So, so one of the things that we've been discussing in our testing task force led by the Broad is how to find sort of the most leading indicators, which are going to be the mild cases, which then progress to hospitalized cases, and some people, and a fraction of those, go to intensive care. So intensive care is kind of the most lagging indicator. And so we're trying to find ways to enhance surveillance so that we actually see the real state of today's epidemic as close as possible, rather than 3 weeks ago's epidemic.
Great. My last question for this round is just your thoughts on the healthcare/public health strategy. So assuming that, and this is difficult because the testing is so far understating what the actual cases are likely, but I assume there's a tipping point where before this point, it still makes sense for us to be tracing contacts of folks who have confirmed cases and trying to isolate them and isolate everyone else that they have come in contact with. But if it gets widespread enough, maybe then the entire focus, or most of the focus, should just go to managing hospital capacity and treating folks. Is that the right way to think about it? Is there some sort of shift once we get past a certain number of cases in the population?
That's another great question. Yes and no. I think this morning in the Washington Post, I had an op-ed that sort of lays out a strategy for that, which has very much been my input to the state task force as well, and is shared by many members of that task force. We'll see how it all plays out, because there is a variety of opinions. But my view is that if there is a person who is known to be a case, they should, of course, be isolated. And to the extent there are resources to do contact tracing, that will help to protect their contacts. The question is, the question is sort of, do we make that the centerpiece of the strategy, or do we do that opportunistically because it's a good idea? As the number of cases grows, it becomes essentially impossible. And New York City, for example, realized last weekend, well, the people on the front lines realized before last weekend, and the mayor realized last weekend in New York City that this was unsustainable, and they switched and stopped doing contact tracing. I think Massachusetts is not quite there yet, and I don't think the public health system is unable to do tracing of the cases they know about. The problem is it can't be the centerpiece of the strategy, because when you're only tracing, when you only know about, say, just roughly arbitrarily, say 10% of cases, that means that even perfect control of all the chains of transmission from them means you're only stopping 10% of the transmission. And we need to stop closer to half of the transmission in order to get this epidemic under control. So it can't be the centerpiece. And if it starts to distract from other measures, then that means it's a bad allocation of resources. If it can be done, it clearly should be, and especially if they're, if you have a nursing home worker or something who's exposed, you don't want to just sort of say, well, we don't have time to pay attention. But my view is at this point, we should be focusing on, if you're sick, if you have a respiratory, if you feel like you have a flu or a bad cold, and I know it's not always easy to tell from allergies, but many of us know that, can sort of feel the difference. If you feel like you have the flu or a bad cold, assume that you have COVID, because you don't necessarily, but it's more and more likely as it's no longer flu and cold season. Isolate yourself even more than other people, than regular social distancing. And testing will be, for the short and medium term, mainly for surveillance and for hospitalized patients and healthcare workers.
Thank you.
Thank you so much for your questions. Councillor Janey, are you there? Council President Janey?
Yes.
I'm going to give the floor to you.
Can you guys hear me?
Yes.
Wonderful. Thank you so much. I want to thank you, Councilor Arroyo, for chairing our first virtual hearing, very important topic. Many thanks to the sponsors of this hearing and all of my colleagues for all the work that you've been doing. in the last several weeks and months. And thank you to our panelists. I was wondering if you could speak more to capacity around testing and capacity around beds, and where you think we are in Boston and Massachusetts regarding those two, based on where you see the curve going.
Yeah, so on testing, it's being increased massively now, thanks to really a great collaboration with the state DPH and the Broad and many academic and public sector and private sector groups. It's not enough to do testing of everybody who might be sick, and probably won't be in the next few weeks, but it might be, especially if we get the epidemic under control through social distancing measures, it might begin to be that as we scale up further, say a month from now.
And can I just ask you a question, Doctor? Do you worry about the messaging and the terms that we use? For example, social distancing versus physical distancing? Like, I think we're confusing the message.
Yeah, and I've even written about that.
Like social distancing versus physical distancing, because I think that's what we mean.
Yes, and I've even written about that and now slipping back into bad habits. So thank you for that point. I think as I said before, the virus transmits through physical direct contact and through physical closeness because of coughing and sneezing and other sort of ways of getting it from one human to another. So keeping our social ties in place as best we can is absolutely critical, and all of us are struggling to do that.
So I guess just back to the capacity question. In terms of testing, I understand that many more are available. We're doing more tests and more people are testing positive because more tests are available. I guess my question, if testing is part of the strategy for controlling the curve, are we yet at the capacity we need to be at to control the curve? Are we doing enough to control it, or are we just finally starting to keep up?
No, we're not. We're certainly not there yet. And I mean, to give you a sense, Massachusetts is probably among the 2 or 3 best, maybe top 5 states in the country in terms of capacity, I think, although it's all changing fast. But the US per capita has done 30 times less testing than South Korea per capita. And Korea is one of the countries that used very widespread testing as part of its control measure. And it's hard to compare because the number of cases is different and all of that. But in short, no, we do not have the capacity to do what some people are very strongly advocating, which is essentially to be able to contact trace everybody, both because we have too many cases and because we have too few tests. And I don't think we're going to solve it unless we fix both of those.
Yeah, and so my last question, I know my other colleagues want to jump in here, but it is around tracing, and so I know that has to be part of the strategy. I worry that as more and more cases are identified, it's going to be harder and harder for us to trace. And I also worry about the messaging. And so as we're speaking with families about point of origin and who was in contact with whom, I worry that we can potentially get into the blame game around who in the household infected, particularly when we have households in Boston that are multi-generational. And so there are school-age children in households, along with not only grandparents, but great-grandparents. And so I want us to be careful about how we talk about tracing that doesn't somehow end up blaming family members for infecting, other family members. And if there is any guidance that's already written about this, that would be helpful for us to share out with folks about how to talk about this within our households, within our families, as more and more cases are identified.
Yeah, right. I couldn't agree more. That is not my specialty, and I wish I had better answers. But I think we're all dealing with it. We have kids. Lots of people have multiple generations in their household, and I think the challenge is that you want to inspire people to be careful and to protect themselves, both as recipients of infection and as donors of infection. And you also don't want your child to feel guilty for infecting somebody that they couldn't have helped.
Exactly.
I don't know that's above my pay grade.
Well, thank you so much for your work. Thank you, Mr. Chair, and I look forward to the next round of questions. Thank you.
Councilor Mejia. Carrie, you can unmute Councilor Mejia.
Am I on mute? Unmuted?
No, we can hear you.
Okay. Thank you, Councilor Ricardo, the chair, for hosting this, and my colleagues, Michelle Wu, Councilor Michelle Wu, and O'Malley for hosting this. I just have two questions, Doctor. One is, what I've noticed is that the whole idea of who is at risk has changed. In Italy, we were looking at the population of our elders. Now I'm hearing that we are looking at folks who are in between their 40s and 50s, and even young people are getting infected. I'm just wondering what if you know of anything, what has caused this disease to morphous in this virus to morphous into impacting other age groups. And I'm just wondering what that's all about. And I am particularly concerned about our most vulnerable populations in the city of Boston. We already have, as you may or may not know, Councilor Ricardo had put out, Arroyo had put out a hearing order around the health disparities, particularly for people of color. And given the state of health affairs here, I'm just wondering what, if any, advice you could give us so that we can start thinking about our most vulnerable populations as this virus continues to spread. That's one question. And then the other question that I have is in regards to what best practices that you might be able to share with those who are health workers who have to report to work, in terms of how do you best protect yourself when you have to be in close proximity to folks? Any best practices that you can share around that would be helpful.
Okay, I'm going to take some of those and punt some of them to people who are more qualified than I, who will speak later. But in terms of your first question about who are the risk groups, I think a good thing to keep in mind when understanding this epidemic is, imagine you're looking through a very dirty window, and somebody's slowly cleaning the window, and you're getting to see a little bit more. Usually, it's not so much that what's on the other side of that window is changing; it's that your view of it is changing, and that is almost always the best way to imagine new information. Is that we're learning more of something that hasn't changed so much, rather than. And I use that metaphor because I think it's so confusing to get all this information for specialists as well as people who have other things to do in life besides study viruses. But for example, there's no evidence at all that the virus has changed. There is evidence that our understanding of who it can infect has changed. And that's in two ways. So early on, we thought children might not even be getting infected. And then from particularly one study in southern China, but also from other data, we've begun to understand that everybody can get infected at roughly similar rates, but the children are mildly, are much less symptomatic on average. And so if you just look for sick people, you find a lot fewer children and a lot fewer older people. And that principle, or that problem of getting an observation that's not representative, is then repeated over and over and over. So when you referred to the new information about younger people getting infected, you might be referring to the CDC's report that came out a few days ago. Mm-hmm. And again, the issue there is that in order to be a known case in the United States in the presence of highly inadequate testing, you either have to be a severe case, or you have to be somehow happen to get observed by public health. But the best way to get observed by public health is to be severe. So if you look at all the cases, there may not be that many severe cases in children, and there aren't that many compared to the mild cases. But the ones who get in the data set, the ones who get in the paper and get analyzed, are preferentially the severe ones. They're the ones who got tested and got confirmed. So that is not, I was a little surprised to see that come out of a place like the CDC, because it was very misleading in some sense. It wasn't lying about what the data said. It's just that the data don't represent the population. The data say there are a lot of severe cases in all age groups, and that's true. But compared to the mild cases, which aren't in the data, it's still true. It's still much worse if you're older. And then the last thing to say is it's a continuum. So there are severe cases in every age group. There are more severe cases in older age groups as a proportion of all cases. So your risk is going up with your age, but that does not mean that every case in small people or young people is mild. It just means more of them are. I hope that helps.
Yes, thank you.
So, and I really mean, we're all trying to figure out, like, we don't even know which part of the window is muddy. We're just trying to figure out what's as the data emerge, how to fit each new piece of data into our understanding. But the virus, as far as we understand, is not different now than it was a few weeks ago in important ways. Your other question about vulnerable populations, I think you have other speakers today who are really expert in that. And I would just say that every epidemic that I know of has been more severe in vulnerable populations for all the obvious reasons. With a respiratory virus, I think there's a particular concern about poorly ventilated dry places, which includes a number of the shelters that I've been in my life. That I've visited in my life, and I think that's just one obvious place where transmission could be a concern. But I think you have other speakers who can give you a more professional response.
And the last question in regards to what can healthcare providers and those who are essential workers who are on the front lines, what are some recommendations to keep physical distance considered?
Yeah, I mean, it's sort of a whole discussion in itself, and I'm not a healthcare worker, and I don't want to really get into the details, because again, it's not where I can add value over other speakers today. But I think the crucial issue is that personal protective equipment is in very, very short supply. This is a national failure, and we should all be banging on the doors of our federal representatives to fix this problem by shifting manufacturing on a massive scale to making personal protective equipment. That's my recommendation, but locally it's going to be a big challenge to solve it.
Thank you.
So I see Professor Lipsitch, if you can hold for a second, our nurse from Kearney, is it Margaret Conlon? If you can unmute Ms. Conlon. She has to leave at 2 p.m. So I just want to give her a chance to speak. Many of us know that Kearney is converting over to being a full coronavirus hospital. And so I would just like to give her a chance. So Ms. Conlon, you have the floor.
Hi, can you hear me?
Yes.
Oh, good. Okay. I guess my biggest thing that I would like people to know is that we do not have the PPE to take care of the patients properly. And my fear is that we're going to be spreading it more than we need to, and that the nurses are going to start getting sick. So that's probably the biggest thing. We don't have the equipment we need to do the job.
So Mark, is it Ms. Conlon?
Yeah, you can call me Peggy.
Hey, Peggy. So first off, I just want to thank you for the work you're doing. I know I speak on behalf of my colleagues. We understand that the work you're doing is very difficult and very integral right now.
Yep.
I have some questions specific to the Carney.
Sure.
What measures has the Carney implemented as you're aware of for what's happening now?
I'm sorry, can you say that again?
So in terms of the Carney converting over to being a coronavirus facility,
Yep.
what things can you kind of report back to us about what that looks like on the ground for nurses?
Yeah, so what they did was make a floor. They took a floor, the 5th floor, and made it a negative pressure area. So I think there are probably 10 beds up there. In those beds, what they're doing is any other Stewart hospital that has a patient that tests positive in Massachusetts can be sent here. But we also have our own patients that might have been on another floor and they test positive, so they'll go there. So that's what they did in that particular area. And I think there are plans to do more of that, although as a member of the staff, we don't always get to know everything that's going on, but there is like one specific geographical area that the positive patients are going to, except for the patients that are really, really sick that are positive, they're in the ICU.
Okay, and so just really quickly, just a negative pressure room for folks who don't know what that means.
Oh, so like a negative pressure room is a thing they do to the room to try to keep the droplets from getting on us. In other words, it gets pulled away from us.
Okay.
So we have a couple of those rooms in the hospital, but they rigged up these rooms to be negative pressure rooms. So it's a little bit different than our usual negative pressure rooms, but there's like these big hose things going out the window to make the whole floor negative pressure.
Thank you. And so I'm gonna just, unless you have anything that you'd like to add before I open it up to questions.
No, I think some of my other colleagues, you know, they'll be on too, and I'll stay on for as long as I can, but nope, that's fine.
Does anybody have any questions for Ms. Conlon while we have her right now? People with video, if you just raise your hand if you do. Counselor Flynn. Can you unmute Counselor Flynn? Counselor Flynn, you have the floor.
Thank you, Councilor Arroyo, and thank you to the central staff for putting this on and for the professor testimony. I know this is a difficult time for everyone. We fight this epidemic. One issue I focused and had a conversation with some nurses recently is getting them equipment that they need. It's critical that we continue to provide the necessary resources for our nurses, for our medical professionals that desperately need this. I had conversations with nurses as well recently from various hospitals and talked to the Mass Nurses Association, and they're doing an outstanding job. But what can we do to get more of these supplies in the hands of the professionals that really need them?
Are you asking me?
I am. I'm asking you in what role can, what role can the public play? What role can the government play to make sure that, you're able to do your job effectively with the equipment that you should have?
Yeah, I mean, I'm not sure what the public can do except for, because what's really, the scary part is people want the N95 mask, which is a mask that we get fitted for annually that helps prevent droplets from being inhaled or, for us to breathe them in, whatever. Those seem to be the hardest things to get our hands on, and those are the things we want the most. So I know there are people out in the public that are talking about like sewing masks and different things like that. I just don't know that they take care of the droplet the same way that the N95 mask would do. So that's probably the big thing, the N95 masks. I don't know where else to get them. The yellow gowns and also the face masks. Those are probably the biggest things because, you know, we don't mind going in the room. We just want to make sure that we're covered and we're not bringing it home. The other issue is, you know, we know that we've been in rooms where we've been exposed to the virus and there really isn't anything they're doing here to test people or say, you know, what should I do? Other people are quarantining themselves because they were near someone who wasn't really even sick with the virus. But here, we know we've been in the room with someone who was sick, maybe unprotected. We didn't know they had it at the time, and we're not quarantining ourselves. So our fear is that we're like spreading it instead of getting it better.
Right, and one part of that, I was talking to some nurses recently, and they want the ability to, you know, quarantine if they are exposed to patients, but quarantine, hopefully these colleges and universities will have dorm rooms available where nurses can quarantine in these rooms so that they're not bringing back the coronaviruses to their own families following their shift. So that would be,
Right.
that'd be a critical part of this public health outreach as well.
Yeah, I'm not exactly sure why we became the hub for this, because it doesn't seem like we really have any more equipment than anybody else. It gets sort of like divvied out, you know, in the morning, okay, we just got a shipment of this in, but by the time the night staff, by the time we come back in the morning, it seems like people will tell us they didn't have what they needed during the night.
Thank you.
You're welcome.
Thank you, Councilor Flynn. If I can go to Councilor Campbell, who has some questions for Ms. Conlon. She's on the phone. Carrie, if you can unmute her, it's the number there at the bottom. You're unmuted, Councilor Campbell.
Hi. Thank you, Councilor Ricardo, and thank you for to the co-sponsors as well. And thank you guys for participating on this call. Just my two quick questions. One has to do with infants, not only because I have a 3-month-old, but I've also been getting questions from folks in the community with respect to infants versus toddlers or children generally. And then the second has to do with HIPAA requirements and compliance. So as counselors, as you can imagine, many of us have been asking questions around the data. So when we hear about confirmed cases, now a death in the city of Boston, we would like to know, I would like to know, what neighborhood are these confirmed cases showing up in? Where is the death? And some folks have pushed back saying HIPAA issues. I disagree, but I'm just curious in your line of work, if you've seen that come up and if the HIPAA laws and rules, frankly, go out the window with respect to infectious diseases and other laws. Thank you.
Thank you. So I'm really an adult critical care ICU educator, so I don't know anything about infants and children, so I'm sorry. But I do know that nurses have been concerned that when a fellow staff member or a question that someone has gone out, the nurse will say, did they test positive? Were they symptomatic? And we'll hear, oh, I can't tell you that, it's a HIPAA violation, but it's kind of like, well, I should know, shouldn't I was exposed to it. So I would say, yes, that was going on, and I don't think it's right myself. I don't need to know anybody's name or know anything, but I want to know if I was around somebody who was exposed.
Councilor Campbell, do you have any other questions?
No, but if, at some point another panelist might have more information, I'd love to hear it with respect to those questions. Thank you, and thank you guys for your hard work. Thank you, Councilor Royal.
Thank you. So people on video, unfortunately, are getting a little bit of an advantage in that I can see them quickly. So anybody on video have any questions who I haven't called for, Ms. Conlon? No. Okay, so if you can unmute Matt O'Malley, who's not on video, very briefly. I just want to make sure. Matt, do you have any questions? Councilor O'Malley, do you have any questions for Ms. Conlon?
Oh, sorry about that. No questions. Just thank you, Ms. Conlon, and to all of your colleagues. You're in our prayers, our thoughts, and we're incredibly grateful for you and so many exceptional Bostonians. Be well and be safe.
Thank you.
Counselor. Counselor Edwards, do you have any questions for Ms. Conlon?
Hi, everyone. No, I don't. And I just want to say thank you. And it's really awesome. And we're able to have this hearing.
I appreciate that. Thank you.
Thanks.
Counselor Wu, you also don't have a camera on, so just do you have any questions for Ms. Conlon?
I'm good. Thank you so much.
Thank you. Okay, so thank you, Ms. Conlon, for your time.
Thank you.
If we can go back to Professor Lipsitch. If you can unmute Professor Lipsitch for me.
Yep. Hi.
Thank you. There we are. If we could just finish your round of questionings. I think Kenzie Bach was next. Counselor Bach, you have the floor. If you can unmute Counselor Bach.
Hi, thanks so much, Mr. Chairman. Doctor, thank you so much for being here with us. I think it's a moment where obviously there's a lot of anxiety, and information can really help to quell that and also help people do the right thing. And I was wondering if you could speak a little bit about, on your slides, you had a mention of sort of ventilation and humidification for buildings. I mean, obviously there's questions of the level of ventilation that we build our buildings with, but in terms of the buildings that we actually have, what should building managers and operators be thinking about on that front?
Yeah, this is not my area, but I have just been educated by my colleague Joe Allen, who you may want to ask to come and talk to you about that. My understanding is the obvious stuff is opening windows, improves ventilation. Using air purifiers improves circulation, and they can help. And using humidifiers also helps. And then the other thing that I've understood from him is that the HVAC systems in many buildings have filters that are, haven't been changed on the regular schedule, and can be replaced for a few dollars, and that makes a big difference. But I am not a building engineer by any stretch, so that's my layman's understanding.
Well, thank you. Appreciate it nonetheless. And then I was wondering if you could just speak a little bit. I mean, one of the things that I think many of us have been reading and hearing is that, and you alluded to it, that it seems as though this virus might be spread more by asymptomatic individuals than your typical virus. And if you could just say whether that's true, and sort of in light of that, obviously that's my layman's understanding, part of the reason why social distancing is so important, and part of the reason why we just need people in general to minimize their trips. But I would love to hear your thoughts on, given that, when in situations where we do need volunteers in person for things, in situations where people have to interact with others and they aren't symptomatic themselves yet, like what should people be especially thinking about and doing?
Yeah, so there's some controversy. I think most of my colleagues think that there's a significant contribution from asymptomatic transmitters. It's not totally settled, and the World Health Organization has been making the opposite claim, and I've been trying so far without success to understand the basis of that claim. So it's an area of controversy, and I don't usually, it's not my habit to disagree with the World Health Organization unless I've tried very hard to understand their position, and I have, and I don't. It's not really more than other viruses. Flu probably is kind of similar to what we think this coronavirus does. In terms of practicalities, what it really means is that you should keep social or physical distance, not only from sick people, especially from sick people, but also from others as well as possible. That obviously is a continuum. If it's a spouse or a sibling or whatever, that's going to be different from a non-household member. But it just means that there is some amount of transmission that you can't predict, and that really I have been told that psychologically it's easier to think of it as trying to keep your distance so you don't infect them, rather than so that they don't infect you. But so that's, I don't know if that's helpful, but that's kind of the principle. And everybody has to have a certain amount of human interaction for various reasons, to buy groceries and other things, if nothing else. So you can't bring it to zero, but one of the things about infectious disease epidemiology is that you can bring the number of cases down without getting transmission to zero. Otherwise, we'd never have a decline in the number of cases. We just have to cut it down enough so that each case doesn't generate more than one other case.
Right. So it's not all or nothing. It's every incremental
Exactly.
little.
Yeah.
Every people eliminate. Yeah.
It's a societal exercise in learning to think probabilistically, which I've learned from my own in-laws is very hard.
And on that front, you know, if I'm in the grocery store and someone gets close to me, like, you know, should I be doing this? I mean, we want to save our masks right now for our, you know, our medical first responders, but should people be wearing scarves, bandanas? I'm just sort of curious how much you think that makes a difference.
Yeah, I don't think it hurts. The evidence is pretty soft on masks, and I got a question from a reporter this morning about this. You know, I don't think people should go out and buy masks because we need them for healthcare workers. And the evidence that for regular people they do much good is unclear. But if you have a bandana or you can sew a mask, it's probably not going to hurt.
Great, thank you.
Thank you. Councilor Braden, I'm going to unmute you. I just found out, everyone, an hour into this that I can actually unmute folks. So, Councilor Braden, you have the floor.
Thank you, Councillor Arroyo. Thank you so much for holding this hearing. One question I had was with regard to concerns about healthcare workers having to reuse masks and trying to extend the shelf life of these, and if it's not a specialized mask. So can you speak to the dangers or risks of reusing all masks that have been used all shift? Or I'm hearing some rather concerning reports about health professionals reusing masks. Thank you.
Yeah, I don't have anything specific to say except that it's clearly worse than using them the way they're directed. I mean, they do begin to break down over time. Yeah, I mean, I don't know the details, but clearly this is a second best solution when we don't have enough masks.
1 second, Councilor Braden, appears you have muted.
Yeah, I've got it. Thank you. That's all I had for now.
Thank you, Councilor Braden. Councilor Edwards, do you have any questions for Mr. Lipsitch?
I have a reference number for you. Do you want me to send you an email with that in case?
Councilor Campbell, do you have any questions for Mr. Lipsitch? You have the floor now.
Hi, can you hear me?
Yes. Yes, I can.
I just have two questions. Thank you very much, first of all, for joining us and taking this time. Really appreciate it. Two questions the same. One is with respect to infants, if you have anything to add there, or if you know a little bit more. And then the second has to do with just the HIPAA issues and sort of that making it challenging to get information.
Yeah, I don't know. I mean, this is what the CDC would be doing, is getting the data on these specific questions together if they were in full functional mode. And I'm sorry that I can't do that.
No problem. Thank you.
And so with that, I'm going to just thank you for being here. I'll do one more quick round if folks have questions, but one of my one of my questions that I do like to ask in these instances is, I know you've answered a lot of questions for a lot of different folks, not just here, but over the last week or so. Have there been questions that you wished have gone asked that went unasked? Is there anything that you think folks aren't necessarily focusing on that they should focus on?
That's a good question. I mean, I think the big issues in my domain of expertise have been covered. I think, you know, because I'm a layman in the other domains, I'm much more concerned about the questions like vulnerable populations and the economic impact and all of that, because I think we are in a potentially quite long-term slowdown in economic activity. And so to the extent that the city council is able to really keep an eye on the disruptions of education and people's pocketbooks, that's certainly a more within our local control than the fact that we don't have enough masks nationwide.
I appreciate that. And then as I open this up for the second round, just if you could raise a hand if you have a second round of questions. I just see Councilor Mejia, so I'm gonna let Councilor Mejia go. Councilor Mejia, you have the floor.
Yes.
Councilor, and I see you too.
And I'm sorry if this is not falling within your domain of expertise, but I'm just curious as to whether or not you know if once you've been infected, can you be reinfected? Like if you get better, can you get sick again? Just curious if you happen to know that.
Yeah, so I think I know as much as anybody, which is that we think we have a good idea, but we aren't 100% sure because this is a new virus. So when you get infected with this virus, at least typically, it now seems that you make an immune response. That's not surprising. That's what people do with viruses. The length, the effectiveness and the duration of that immune response and whether it gets less effective over time is one of the questions. And whether there's some people who don't mount an appropriate immune response is also a question. But I think based on what we know from other viruses, the vast majority of people who get infected will mount an immune response that will be protective against future infections to varying degrees. What's known from other coronaviruses, not that closely related to this one, sort of in a different class of coronaviruses, but still coronaviruses, is that if you experimentally in a lab give a human an infection with a common cold type coronavirus, and then a year later give them an infection, try to give them an infection with the same virus, they're less likely to get sick. They basically don't get sick, and they shed less virus when they get infected, but many of them do get infected again. So reinfection is a possibility a year later. We don't know this. We would expect, because the infections are a bit more intense with this virus, that people will have a stronger and longer lasting immune response. And some of the stories that have come out suggesting that people get reinfected. Some of those stories, maybe all of them, are cases where someone tested negative and then very soon afterwards tested positive. And I have been very strongly of the opinion, and most experts in immunology and other related fields that I have seen quoted say the same thing, which is that most likely that's a false negative test. So they were positive the whole time, and one of the tests looked negative because they didn't swab the right place or whatever. And in infectious disease epidemiology, we always expect that some proportion of tests will be false negatives, because just if you don't get enough virus on the swab, for example, you don't see it. So I wouldn't worry about those studies, but I think the extent of immunity is something we're just going to have to learn about.
And then one last question. We hear a lot about, what happens when you are when the virus has gotten to the point where you're just going to lose your life. But we don't hear often what it looks like when you are sick. Can you help our audience understand what it looks like when you have the coronavirus? What's happening to you? Is it just a cold and does it just go away? Does it progress? Can you just help us understand the life of this virus once you get it?
Yeah, I'm not a medical doctor, and I'm very strongly try to keep in my realm of expertise. So I'm going to answer that briefly and hope that one of your later speakers will give you more details. There's clearly a spectrum there from very mild disease where you maybe just hardly know you have it or think you have a cold, to feeling like you have the flu. And I once saw a decision map saying if you think you've been hit by a train and you haven't been hit by a train, then you have the flu. So there's sort of really bad headache, muscle ache, headache, cough, fever, and all of that. That's another part of the spectrum. And then worse than that is sort of, your lungs feel inflamed and you really have a hard time breathing, at which point you're close to you're at the point where you really need to seek medical help. And then beyond that, there's even more severe. So that's a very simplistic answer to a very hard, complicated question, but I think it's clear that all of those things can happen. And I hope one of the physicians will chime in with a more professional answer.
Councillor Flynn, you have the floor.
Yeah, thank you, Councillor. I just had one brief question and a comment. One of the critical parts as a city councilor is communicating with our constituents, making sure we provide the most updated and accurate medical information available. We have daily conference calls with Mayor Walsh and his administration, and they are available practically anytime we need them. Knowing all that information, what's the most effective way for us to communicate with our constituents, especially a lot of us that have constituents that are non-English speaking, persons with disabilities, or hard to reach constituents. They might be living in public housing as well. Do you have any advice that might help us on our communication efforts?
I'm not sure that I have anything really to advise you other than point them towards authoritative sources. The CDC, as I said, is not giving out enough information, but they're giving out good information when they do. The Mass Department of Health is giving out good information. Boston Public Health Commission is as well. So point them to authoritative sources. Other state governments are probably doing more than any one state government can do. So I would just emphasize that, and not sources of information that are either sensationalistic or trying to sell something, which there's a lot of going on right now. So that would be my one bit of advice.
And just as a quick follow-up, I've been communicating to my constituents in Cantonese, Mandarin, and Spanish. I know Mayor Walsh is as well, and I know all my colleagues are, but are communicating as well to their constituents in various languages. But it's critical that we provide the most updated, accurate medical information to the residents that need it most. And that's also our immigrant neighbors throughout Boston. So it's critical that we really provide the right message to them and get them the updated medical information.
Absolutely.
Thank you,
agree.
Professor.
And with that, I believe that is actually all the questions. Counselor Sabi George, I can see you on video. Do you have any questions for Mr. Lipsitch before I cut him loose? Let me just, hold on, let me unmute you. There you go.
I have one question that either maybe the doctor could answer or one of the other panelists. I'm sorry, I stepped away for a few moments. I am curious about what other communities have seen as, I'm sorry, I'm just distracted by something. I'm curious as to what other communities have seen in regards to the impacts on first responders.
All right.
I don't have an answer to that. I'm not actually sure.
I apologize, it's unrelated. My laughter is unrelated to this hearing. I'm sorry, it's terribly rude. So other communities, when we've seen the virus impact first responder communities. So here in the city of Boston, we know that we have a police officer and an EMT that have positive tests. I'm curious as the impact that could have in responding and directing care and what we've seen in whether it's other parts of the country or other parts of the globe.
I don't have any information about that. I'm sorry.
Any of the other panelists?
I guess we'll find out when we get to them.
Great.
They're all muted.
Thank you, Councilor Royo, and congratulations too on your first hearing.
Thank you.
Doing it in such a fantastic way.
Yeah, this is it. This is interesting. Okay, so Mr. Lipsitch, I think that is everything for everybody. I want to say how deeply I appreciate the work you're doing. I know you've been burning the wick at both ends, so I hope you do get some rest. I appreciate you taking initiative and just having lunch now because I know we were holding you up. So I really appreciate that you didn't let that happen. And so thank you so much for coming here and really helping put, the Boston public, I think the more information that our residents can get, the better for everybody's sake of mind and peace of mind. And I think this has been very helpful so far. So thank you so much. I do appreciate your participation.
Thank you very much for having me. Okay.
Thank you.
Bye-bye.
You're free to go.
Okay.
Appreciate you. For other panelists who are on here, I appreciate all of you being here. I have a couple folks that are time restrained, so I'm going to try and go through them. If I can get it to, let me just see if Mr. Antonellis is on. Mr. Antonellis, are you there? And sorry if I'm butchering your last name. Oh, hold on.
I'm here, Counselor.
Okay. Great.
You're pretty accurate. Antonellis, but Antonellis.
There we go. Perfect. Thank you. I believe people should be called by their names. So, Mr. Antonellis, thank you so much for being here on behalf of the Sheriff Department, the Suffolk County Sheriff's Office. I know we have a lot of questions about, the steps that have been taken in place to protect civil liberties as well as protect the population itself. And so I'm going to give you the floor to just kind of speak on that. Please know at 2:45, I'm going to put on a hard stop. We can come back to you if other folks have questions, but I know that our representative from 32BJ has to leave around that time, so I want to make sure they at least get a second on the floor there. So if you can now take the floor, and then I'll open it up to questions again.
Okay, absolutely. Can everyone hear me okay? Okay, great. So Sheriff Tompkins asked me to participate on his behalf just to provide an overview of where things stand for the department, and then I'm happy to answer questions. So I'm going to just go through this really quickly since I imagine there'll be a lot of questions. In regards to the Suffolk County Sheriff's Department, we stopped visitation 2 weeks ago. Lawyers have been permitted to see their clients behind glass. We are allowing clergy as well if inmates need to see their clergy person or other religious representative. That will be starting back again this week. We have halted partners with the department and different volunteers from entering the facility at this time. Starting last week on the 16th, non-essential employees were instructed to work from home. This week, we are continuing that process, although we are in some cases on a person-by-person basis determining whether the individual should continue to work from home or should be reporting to the department. And in those cases, I'm not talking about corrections officers. I'm talking about non-corrections officers like myself. Anyone entering a department facility is subject to a temperature check when they enter. Those with a temperature reading above acceptable norms is asked to return home until their fever has subsided. So we are trying very hard, as well as any inmates that are coming in, we are screening to do our best to ensure that COVID is not entering the facility. At this time, I am aware of no instance of any inmate or employee who has tested positive for COVID-19. Inmates we have changed policies regarding telephone calls. Inmates are receiving 2 free calls a week for a 15 to 20 minute duration, and we are looking at ways that we can expand this service. Programming inside the department behind the wall is being curtailed in an effort to limit movement and groups of people moving up through the facility. Programming that is still being offered is being offered inside the unit directly. In the past, inmates would be able to move through the facility to a centralized location to participate in programming. We've shifted that programming to inside the unit. The Peace unit, which is our 18 to 24-year-old men, the specialized unit is still operating. Those gentlemen are still there. Their programming is continuing. Our OASIS program, which is our substance abuse treatment operating at the House of Corrections in South Bay, that is still proceeding. We are asking officers and caseworkers still reporting to work about helping out with the education program to ensure some continuity in the education program, since we've asked our outside partners and volunteers to not enter the facility. The department is aware of discussions taking place between the district attorney, the public defenders, and the courts relative to early and compassionate release of some inmates. We will abide by the decision of the courts in this matter. Expanding on that, if individuals we find are being released and they have a safe place to go to a family member, we are very happy about that. We are concerned about inmates who would be leaving the facility and would be homeless upon exit. In that case, and this will be the individual's decision, but if they prefer, we will allow them to remain until a more permanent solution can be found, so that they will at least have access to a bed, warm meals, medical care, and will not contribute to an overload of the system providing services to the homeless population. Again, that is their decision. The sheriff wanted me to stress that the situation inside the department is fluid, and that we're working with all outside partners to ensure that we're following best practices at this time. And that is sort of a 40,000 foot view of what's going on at the House of Corrections and the Nashua Street Jail. And I'm happy to answer any questions.
I appreciate that. So here's what I'm actually going to do, folks. We're gonna change the format a little bit just to respect folks' time. We have other panelists here, and so what I'm going to do is I'm going to actually give each panelist a second to essentially do what Mr. Antonellis just did, which is give kind of a brief overview of what you feel you can speak on and why you're here to speak. And then I'll then turn it over to the counselors, and basically we'll try and have our questions directed at who they're most relevant to. If the counselor knows who they're asking their question to, just say that, and then we can kind of unmute it so that there's some order still. But I'd like to let everybody kind of have their say, because folks are running up against their stops, and I want to make sure that folks can get back to doing what they got to do as they're here. So thank you so much, Peter. I'll get back to you once we're done with everybody else. If I can just move it over to Mr. Landrigan. If you can take the floor really quickly, just introduce yourself. You're unmuted now, and just speak to what you're able to speak to. I would appreciate that. Thank you, Mr. Landrigan, for being here.
Thank you, Counselor. So my name is Philip Landrigan. I'm a medical doctor, grew up in Boston, grew up in West Roxbury. Worked for many years for the Centers for Disease Control, and I'm now the director of the program in global public health and the common good at Boston College. And a couple of points I'd like to make. First point is I'd like to speak strongly about the importance of a stay-at-home order. I'm delighted that Governor Baker this morning put out a stay-at-home advisory. That's clearly an important step in the right direction. But my concern as a public health physician is that it doesn't go far enough. Just this morning, I'm holding it up here, you might be able to see it. Physicians for Social Responsibility, the Greater Boston Chapter of Physicians for Social Responsibility sent an open letter to Governor Baker urging that the governor go beyond an advisory and actually put out a stay-at-home order. And I'll read just a few words from this letter. It says as follows: given the enormous energy already invested in this unprecedented effort to check the pandemic, it would be a terrible shame to see it spiral out of control in our Commonwealth at this point for want of the last and arguably the least difficult remaining step, which would be an immediate stay-at-home order, a shelter-in-place order. I know there are issues of balance. Professor Lipstitch spoke about the importance of balance, and I subscribe always to the importance of balancing public health needs against civil liberties. But I think we're in a situation here, a pandemic situation, where the protection of the health of the public has to take precedence. You always have to be mindful of the balance, but I think the protection of public health should take precedence. There are some countries in the world, it's probably not the American way, where in Norway, for example, people get fined, I believe it's $400 if they're caught outside their home unless they're a first responder or a doctor or a nurse, somebody with a valid reason to be out. I'm not sure we could ever go that far in the States. It's not how we do business, but I think we need to go farther than we've gone before, because the real need here, as Professor Lipstitch laid out so very clearly, is to flatten the curve, for the simple reason that if we don't flatten the curve, our capacity in the hospitals, in the intensive care units, the ICUs, to handle patients with this virus is going to be overwhelmed. I know it doesn't feel like it today, we're not there yet, but it's like the train is coming down the track, and whatever we can do to slow the pace of the train, to flatten the curve, to delay people from becoming sick and hitting the hospital is a good thing to do. I also would like to follow up on something that Councillor Flynn said a couple of minutes ago about the importance of communicating the latest, the most accurate information about this epidemic to the public. I couldn't agree more. Just a few minutes ago, I sent a link to Councillor Wu, and I would like to thank Councillor Wu for having invited me to speak before this hearing. I sent the councillor a link to a very excellent website, which is available at no cost online from Johns Hopkins University. She might want to share it with the rest of you. They update this website several times a day, and it's an online interactive map that presents the most current up-to-date information on the pace of the epidemic around the world. And you can look at the global map, and then you can click on any one particular country, such as the United States, and see almost hour by hour what's going on here, and see the rising toll of disease and death. And then finally, I didn't come here to complain, because I think this is a time that we all have to get into the business of working together. But I think once we're past the acute phase of this epidemic, there's an urgent national need. And I think cities such as the city of Boston can, and Mayor Walsh can play an important role in speaking up publicly and saying that the federal government has let us down here by removing major funding over the past several years from the CDC, by dismantling the Office of Pandemic Preparedness within the National Security Council. Our country has been left without the resources that we need to fight this epidemic. We should have been mobilizing to fight this epidemic back in January, early February, at the same time as Professor Lipstitch and his colleagues at Harvard School of Public Health and the Broad Institute were rolling up their sleeves. Instead, the federal government was sitting at that point and telling us there was no problem. And that's just not the way to deal with a public health emergency. I'm sorry. I didn't come here to complain. For the moment, we should all work together and get this right. But when the crisis is past, we have to restore the infrastructure that we took apart.
Thank you. And then I'll let folks direct questions to you once we get around. If I can go over to Cristel Marietta Ruiz, you're unmuted now. Miss Marietta Ruiz is a representative of 32BJ. 32BJ represents janitors and security guards who are doing a lot of the work. When you hear extra maintenance, when you hear about extra cleaning, they're on the front lines of that. And so I just give you the floor now to speak to your needs and what you would like to speak to.
Thank you. And thank you, Councillor Arroyo, for inviting 32BJ to take part in this larger conversation about COVID-19 preparedness. As mentioned, my name is Crystal Murieta Ruiz, and I am a political coordinator with 32BJ. Each and every day, cleaners, security officers, and airport workers keep Greater Boston offices, public spaces, universities, and airplanes clean and safe. These hard workers are primarily brown, Black, and immigrant workers, and the work that they do is invaluable, now so more than ever, as they are helping mitigate the spread of COVID-19. These men and women are the unsung heroes of this epidemic, of this pandemic, and among those who can least afford to lose wages and benefits during this crisis. These same workers who have stepped forward to do their jobs during the outbreak are facing unprecedented layoffs and hour reductions as office buildings, nonprofit institutions, and public venues shut their doors, and white-collar workers have the privilege of staying home. A growing number of contracted cleaners and security officers are losing work and pay. We know that about 200 contracted Boston Logan Airport workers have been laid off, and hundreds more are facing massive hour reductions due to the coronavirus. And our efforts in this moment, one, call on building owners and universities to ensure the health and well-being of workers and their families by offering continued pay and benefits to all cleaners on the front lines of fighting the coronavirus pandemic. And two, as the U.S. airline industry seeks at least $58 billion from the federal government, we are asking Congress to ensure that an airline bailout package includes subcontracted airport workers, such as skycaps, wheelchair agents, cabin cleaners, and baggage holders. These workers do some of the hardest jobs at the airport, receive the lowest wages, and often do not have access to affordable health care or paid time off. We feel that they must be meaningfully protected in this time and want to give a big thank you to the counselors that have already given us their support with making these asks and fighting for the working people of Boston and beyond throughout the state of Massachusetts. I am happy to take any questions after, won't be able to be here, but if Councilor Arroyo can send them my way, I will be extra cautious to make sure that they get answered.
So really quickly before I let you head out, I see that President Jane, you raised your hand. Do you have a question for Ms. Ruiz? You can just give me a thumbs up if yes.
Hello? Yes.
Yes. Yes. So you can go ahead.
So first, I just want to say thank you for really lifting up those individuals, those workers, the low wage workers, the hourly wage workers in this effort, this fight. We can't forget about them. I have some real clear, specific questions for you because I'm getting calls from janitors. So I'd love the opportunity to speak after, if that would be okay. But I just wanted to thank you for really lifting up these workers. They are at the front of all of our minds as we think of ways to support folks who are hurting economically, financially from this epidemic. So thank you. And I look forward to connecting afterwards about the specific janitors that I'm in contact with.
Thank you, Councilor Janey. I appreciate it.
And so I'm going to now go to Samuel Scarpino. Thank you for being so patient. I know you were one of the first ones here. I know you're the director at Emergent Labs. I know that one of the reasons why I was excited to have you here is you were helping with some of the testing coordination. I'd like to give the floor to you now, just so you can give a little bit of, your opening statement, and then we'll open the floor to questions with everybody else.
Great. Thank you very much for having me and for holding this important hearing. I also want to echo the thanks for all that workers on the front lines, and I certainly include janitors, all the individuals that are out there performing these essential tasks day in and day out that are putting themselves at risk. I want to really thank them for everything they're doing and for all of you for giving them an opportunity to speak today as well. A lot of the work that I do is very similar to Professor Lipsitch, and so I actually don't have much more to add beyond his original presentation, although I will say that one of the areas we've been heavily focused on is understanding the test capacity And that's for two reasons. One, even though Boston, Suffolk County, Massachusetts are leading the nation in terms of tests per capita, we're still far behind where countries like South Korea are. And we know that testing is a critical piece for controlling the outbreak and for surge capacity forecasting for our hospitals. However, the other reason that testing is so important is that it's one of the tools we're going to need to leverage as we restart the economy, as we start to relax some of these measures that are in place. We're going to need to give people the information they will want to have in order to self-isolate if they've been exposed or to understand what their current risk might be. And so as we ramp the capacity now, it's not only going to help us flatten the curve, it's going to help us come back to normal at least a little bit prior to the availability of any vaccine. So testing is really of critical importance right now. The second thing that I would add is we do need to be focused very heavily on individuals who are most at risk, both from a health perspective, but also from an economic perspective. Part of the plan for flattening the curve means that the amount of time we're going to be dealing with this outbreak is going to be longer, which is going to put strain on our communities. And it is largely going to be on the individuals who are most at risk economically. And a lot of those individuals are also the ones who are providing these essential services to our communities, from those that are putting food on the shelves, to driving emergency vehicles, working, in our government facilities. And so one of the things that our mathematical models very clearly show is that both in terms of stemming the outbreak and in terms of planning economically, we need to be thinking weeks, months, quarters in advance. And so while I realize now we're staring at the peak of infections coming, the peak of hospitalizations and mortality coming weeks after that, and we need to do everything we can to provide personal protective equipment to our healthcare workers, to pressure the federal government to release ventilators and help states coordinate efforts to bring those resources in. We also need to be thinking about what is the plan 3 months from now? What is the plan 6 months from now? So that we can ensure that individuals are able to the extent possible, get back to work. So then what I'll add is one key area of research for us in our group is to quantify the amount of mobility reduction associated with physical distancing measures, associated with bar and restaurant operational changes, associated with remote work, with K through 12 school closure, so that when we have to start making these hard decisions, or when all of you have to start making these hard decisions for our communities, you will be empowered with the information to know that, okay, K through 12 school closure had this kind of effect on the way we interact with each other. And so this is what we might expect if we tried to reopen the schools, or that remote work had this other kind of effect. And so perhaps that's a much more critical area to focus on. I'm just speaking hypothetically here because we're still working on this. And so those are the areas that we're focused on. Testing now to try and flatten the curve, testing later so that we can leverage that as a part of a test isolate strategy to try and reopen our economy, understanding the mobility patterns, and also thinking ahead for the next 6, 12, 18 months around how we can best serve those individuals in the community that are both at highest risk for disease, but also highest risk as a result of the economic effects of this outbreak. So thanks again for having me. And I have a little bit of flexibility in time, and so happy to try to stick around to answer questions, but always very, very happy to talk via email or phone if there's any way that I can be of assistance.
I deeply appreciate you having the time, and we'll certainly have some questions for you. I know I will, but I'm going to go to the next folks just so we can make sure that everybody has their say, and then we'll open it up. If I can take it over to Ms. Sheridan. Just a quick update for folks who may not remember, President and CEO of the Greater Boston Convention and Visitors Bureau. There has been some conversation about the economic impact. Obviously, the economic impact is going to be felt by all. perhaps no more so than folks that that require human contact in what they do. And so if you can just take the floor now and speak to the issues you're seeing and the supports you need.
Great. Thank you, Councilor Arroyo, and thank you, everyone. I'm happy to be here. Once again, I am the president and CEO of the Greater Boston Convention and Visitors Bureau. I've been in my role there for the past year and a half, and have been in what we call destination marketing for the past 30 years. In addition to my role here in Boston, I serve on the board of directors of the U.S. Travel Association, which is the advocacy arm of the travel industry at large. So some of what I'll briefly cover will address how they're trying to tackle the economic challenges that are now going to be faced by the tourism industry. I think it's no surprise to anyone that travel and tourism is one of the largest sectors in the Commonwealth. The industry is responsible for $40 billion in economic input, and is also employs 1 in 10 residents of the Commonwealth. So we are obviously a huge factor, and we are also now seeing catastrophic results as this crisis continues to evolve and grow. You know, I think we all started a few weeks ago thinking this was a short-term problem, and we've now learned in our industry that the longer this goes on, the longer the recovery will be for us. So I'll just give you a quick summary of what we've seen from an impact perspective, and then talk a little bit about what recovery steps could be taken once we get past the critical period here. Our organization, just by way of information, has been keeping our 1,800 members of the hospitality industry informed on a regular basis about the crisis. We provide resources via electronic communication, but also you can also visit our website, bostonusa.com, and those resources are readily available there, including links to national portals such as the CDC, the state of Massachusetts, the city of Boston, as well as information on closings and what is actually currently operating. So it's a good resource for all to try and use. Right now, hotels are open, but many are voluntarily closing. They have gone from what we commonly enjoyed as about an 82% occupancy rate down to below 10% occupancy rate. So most of the hotels in Boston, aside from the ones at the airport, are virtually empty right now. And as a result, the hotel owners have laid off significant portions of their workforce. In fact, Marriott Corporation, the largest corporation representing hotels in the city of Boston, has laid off 80% of their workforce indefinitely. We have, as I said, had hotels close voluntarily, which means those entire workforces are now out of work and hopefully collecting unemployment. We know that many restaurants have closed, except for those that have the opportunity to provide curbside pickup and delivery. We're grateful that that is still in play, even given the most recent edict from the governor today, because we do think it is keeping at least a small percentage of our restaurants viable. But the longer this goes on, the greater the likelihood that many of those mom and pop owned restaurants will not survive this crisis, which is actually heartbreaking for us in the industry. We've lost business of all sizes. We've lost meetings that take place individually in hotels. We've lost wedding business. We have lost large citywide events, dozens of them that were scheduled to take place at the convention centers in Boston. Both the BCEC and the Hines are either canceled or postponed to a future date, or postponed indefinitely. Each of those events represents millions and millions of dollars in economic spending in the city. So the repercussions from that will be felt for a long time. As you know, we've postponed the marathon, and we're now hearing that schools are foregoing graduation ceremonies. Most recently, Harvard University announced that yesterday. We appreciate that the state and the city, the Commonwealth and the city have put in place some relief measures, economic relief measures that have taken hold temporarily in the form of shorter waiting periods for unemployment, a softening or relaxing of the requirements to collect unemployment, as well as some loan availability for small businesses. The 10 million that was originally slated for $75,000 loans for the small business community was exhausted quite quickly. I do understand that another 10 million is out there, so hopefully people can avail themselves of that. But 75,000 for many of the businesses in the Boston area is likely not going to move the needle on them retaining or calling back employees in the short term. So what I've been working on is with the U.S. Travel Association is advocating for their larger stabilization package. And I know there's a lot of controversy around the term bailout of big corporations. And this package is actually designed to not put money in the pockets of the heads of corporations, but rather impact the workforce directly, which we're appreciative of. They are actually working to, and this is actually what's in play right now with the larger package in DC, $150 billion for stabilization grants to allow our businesses in the hospitality industry to call back workers and retain them at pre-crisis levels, the availability of unsecured loans for with no or low interest rates, and then for businesses with 500 employees or less, the ability for them to use the existing SBA loan program so that they can access up to $10 million so they can maintain their operations as well. The challenge for the industry is once the crisis has passed us, hopefully sooner rather than later, is not going to be a quick recovery. As you know, travel plans are booked quite far out. The ability to book these large citywide conventions typically takes 5 to 10 years to secure them. So they are booked 5 to 10 years in advance. So we will not be able to recover and regain many of those groups for the destination in the short term. We also have the challenge of when air travel will be perceived to be safe and when our international borders will open up again. So when we do begin to think about what recovery might look like for the travel industry, it will look like concentric circles from a promotion and marketing perspective. First, getting people into the Boston area from the drive market. Second, increasing to the second circle, which would be the Northeast market, the entire US, and then of course working to regain our footing in the international market. One of the big challenges that we will face is that the Commonwealth traditionally has not invested heavily in tourism promotion, so we just don't have any resources in reserve to help us convey the message that we're back open for business. So we are going to need to identify new funding sources so that we can stay competitive with other destinations who are likely able to deploy millions of dollars in promotional funds immediately to draw business back into their communities. We will absolutely be at a disadvantage to the point where it's, it's possible that my agency may be one of those small businesses that does not survive this crisis, quite frankly, because of the lack of available funds for tourism promotion in Boston and in the Commonwealth. So I will leave it at that. I do want to thank, by the way, Governor Baker and the mayor for providing us with the resources that they have provided us to keep our constituents well informed. I hear from probably 10 to 12 small businesses every day about their challenges, and oftentimes we are their only source of information as they aren't able to belong to big national organizations and receive their communication. So what we've been getting from the local level has been very helpful. So thank you very much.
Thank you. And I'm sorry to hear such a grim forecast, but I think we're all preparing to try and figure out how to work on that. If I can go to, and I think we'll have follow-up questions on ways and perhaps we can be of help on that. But if I go to the last two folks who haven't spoken, we have Mary Havlicek, and I'm so sorry for what I'm about to do to your last name here, but Mary Havlicek, is it Cornacchia? Thank you so much for the service you're providing as a nurse at Tufts. And then we also have, and I'm gonna unmute both of you together, Ellen McInnes from St. Elizabeth's. And so thank you both for the work that you're doing now on the front line as nurses. I'd like to, and earlier we had Peggy Conlon from Kearney speak. And so I'd like to just give the floor to you two both together to speak to your concerns, things and ways in which you believe we can help as a council and as a city, and ways in which we can advocate for the things that you need from the state and from the federal government. So please do take the
Sure.
floor.
Okay, thank you. So the M&A is dedicated to supporting nurses and healthcare professionals all over the state. And we're advocating for the safest possible working conditions for everybody. And the variety of differences is astounding from facility to facility across the state. We'd like to thank Mayor Walsh and you and all the council members and the governor for keeping open lines of communications with us. What our members are seeing in some places across the state are, and it's everywhere and we hear about it all the time, is the lack of PPE. And that produces such anxiety for all of us on the front line, as none of us are afraid to go to work, but we're afraid of what the consequences are of not having the right personal protection equipment. Potentially infected individuals are presenting at hospitals that are still not equipped to triage, test, and properly treat them in appropriate settings. And nurses continue to be concerned about capacity to treat the potential influx of individuals with COVID-19 because of years of closures of beds, units, hospitals, and reduction in force across the state. Not all facilities are like that. I will speak to Tufts. Tufts has been very proactive in planning for this pandemic. They started thinking about it and putting some things into place some months ago. In terms of personal protection equipment, we have a stockpile. I don't have numbers. However, it's very concerning because they're rationing it very strictly. I will say to a bonus here is that Tufts has gone out and hired some of the hotel workers for food service and housekeeping within our institution at this time. It's just the PPE thing has everybody scared to death, and we need to do something about that at the national level. We need the president to step up and get the manufacturing going at warp speed, because if we're worried about this today and we haven't even seen the masses of patients that might be coming, what is going to happen next week, next month, in a couple of months? The healthcare force is going to not be available to work because we're going to be as sick as those patients. I'll defer to my colleague, Alan.
Ms. McInnes, you have the floor, so you're free to speak now. We can hear you.
Oh, terrific. Okay, thank you. Ellen McInnes. I'm an emergency department nurse at St. Elizabeth's. I have concerns, as does Mary. Mary, good to see you.
Good to see you.
I have concerns about the availability of PPE. We've been told PPE will probably run out this week. And we'll do what we have to. We'll keep on taking care of patients. I know that at St. Elizabeth's, we're already behind the 8 ball for an average daily census and average acuity. We are short 43 full-time nurses. Stewardess, we're not staffed to where we should be. I'm concerned about what will happen when a facility that doesn't have enough nurses on a good day is going to have to absorb this influx. We have had some donations from the public of some N95 masks and some gloves, some PPE. I think it will help. It will extend us. It will get us into another, might buy us another day. But the uncertainty of what we're dealing with is it's just overwhelming. It's really tough to go in there. We will always take care of our patients as nurses, as healthcare workers. That's what we'll do. We will never not take care of our patients. It's just a question of having the resources that we need. And if I can say, as a resident of Brighton, I recall after the tragedy of the marathon bombing, Brighton was completely locked down. Nothing was open. And I'm wondering if we could do something like that for this. We need to keep people home. We need to keep people away from each other. We need to stop this spread. I know we did it before. It was for a short period of time. We were only on lockdown for a few days. But I think if the city looks like that right now, we might be able to get a little bit ahead of this. The other thing is, on Friday night, I took care of a woman who we thought had a kidney stone. We worked her up for a kidney stone. She had no respiratory issues. She had no fever. And lo and behold, because of an incidental finding on a CAT scan, she is now being tested and probably will come back positive for COVID. She had absolutely no risk factors. It was a very low suspicion for COVID. And I think we're going to see more and more of this. I think what we'll end up doing across the city is something Partners has instituted, is wear PPE for interaction with every single patient. That is a tremendous amount of PPE. We will chew through that in no time, but I do believe that'll be best practice. I want to say thank you to the council. Thank you to Mayor Walsh for giving nurses a voice here today.
Thank you for being here. And so just quickly before I cede the floor to the counselors and their questions, if you could just explain for folks that are listening and say they keep saying PPE, what does PPE mean? Can you just tell them what PPE means?
Certainly. PPE is personal protective equipment. It consists of a face goggle to protect the eye, goggles or a face shield to protect the eyes, some sort of a mask to protect the nose and mouth. Those are all ports of entry. And then some sort of garment to protect the wearer's clothes, ideally something that covers the neck to the wrists and down to about the knees. These are largely disposable. Some things can be reused, but largely disposable. And we need a lot of it.
Thank you so much for just clarifying what that is for folks listening. At this point, I'd like to get folks involved in questions. And what we'll do here is just a brief reminder of who's present. We have Peter Antonellis from the Sheriff's Office for folks who have questions about the Sheriff's Office. We're grateful to have Mary Havlicek from Tufts and Ellen McInnes from St. Elizabeth's here, 2 registered nurses. We have Martha Sheridan from the hotels. Let me just be clear on your actual title. Sorry for this. I just want to make sure that I'm accurate. Martha Sheridan is the president and CEO of the Greater Boston Convention and Visitors Bureau. And so she has questions there. And Samuel Scarpino runs Emergent Labs. He's helped with some of the testing, organizing some of the testing. I know you're also doing models right now for kind of tracking progression. And so I believe that's everybody we have on the line still. So with that, I'm going to ask counselors who have any questions, if you can please raise your hand. I see 2 we don't have on video. So what I'll do, is it basically everybody? Can I just see Counselor? I see Matt O'Malley, I see Ed Flynn, I see Liz Braden, I see Mejia, Counselor Janey, Council President Janey, do you have any questions for anybody? No, I'm just asking for a show of hands so I know. So basically what I'm going to do is just go to everybody. I'll start with Counselor O'Malley since I saw your hand first. And I'll try to give everybody 5 minutes to just ask as many questions of whoever is relevant. You're unmuted, Counselor O'Malley.
Thank you. Thank you, Mr. Chairman. And ladies and gentlemen, thank you for all of your remarkable, heroic work that you are doing. We're incredibly proud of you and incredibly grateful for you. Mr. Scarpino, can we talk a little bit about testing? I seem to, like probably all of us, I've been a voracious reader of all the news and the coverage, and it seems that there are new tests that can detect within an hour. I think some countries have used almost like a phone booth type system for checking. Can you talk a little bit about what it looks like for mass testing capabilities? We obviously know we need space. We obviously know we need resources, but what has been the most sort of effective and innovative way to yield positive, not positive, but accurate test results?
The most effective way that we've seen is a combination of high test throughput, meaning that the results are available quickly, with drive-through testing. And the reason that the drive-through testing is so important is that it keeps individuals out of the healthcare facilities, which is critically important. Obviously, there are experts here who can explain that better than I can. But one of the reasons that the drive-through testing has been so important is that people, whether they are directed there by their physician or another healthcare worker, or in some cases it's just open to the public, those people are able to get a test result without having to go into a healthcare facility. That, in places like South Korea, has been coupled with mobile applications so that individuals can be notified remotely as soon as the test is available and directed according to current best practices and their own risk profile about how they should go about taking next steps. Because for a lot of individuals, that's going to be isolating at home and carefully monitoring symptoms. Again, part of the reason that the response has been so effective in places like South Korea is that people self-isolate, meaning they don't transmit, and they stay away from the healthcare facilities until they are in need of those services, so that we're protecting our frontline healthcare workers and keeping spaces open for individuals that are in need of care.
Okay, that's helpful. So would you say, and I know there's no perfect answer for this, but sort of it will jive with what I've sort of been reading and hearing from other experts, that the South Korea model is what we should be looking to build the infrastructure for here in the United States?
I think that that's a model that we need to look at, because one of the things South Korea was able to do is keep this substantially more under control while balancing the economic effects of the shutdown. And so this effective measures of testing and isolating, you still have to have, isolation, physical distancing, remote work to stem the tide, to flatten out the peak. And so one of the things we need to keep in mind is that we're still way out in front of the peak and dealing with all of the crises in our healthcare centers that we've just heard about. So we're sort of in phase 1 now, but the testing that we're going to need for phase 2 after we get through the crisis over the next month is going to be very important for the economic effects. The other side of this, so you mentioned the rapid turnaround tests. A lot of those rapid tests now are looking for the presence of antibodies, and so evidence of people that have already had the infection and cleared it. And that's going to be very important, both for understanding who's already been exposed and may be protected, but so that we understand the current epidemiological situation. So we don't really know much about how children or individuals with less severe cases are moving the virus around. We heard that from Professor Lipsitch. Those sort of retrospective epidemiological studies can be done so that we better understand the risk profile going forward. But that's, of course, a different kind of test than the clinical diagnostic tests that we're also in desperate need of right now.
Gotcha. Thank you. And is Dr. Landrigan still on the line? I don't see his.
I don't think he is, unfortunately.
Okay, thank you, Mr. Chairman. Well, this is to all of the sort of frontline men and women serving, our nurses, our doctors. Obviously, given our positions, we've are interacting with a lot of people. So many people want to help out. I've heard from a number of individuals who may have either the N95 masks or other type masks. I've sort of been funneling them through Neil Doherty, who works in intergovernmental relations for Mayor Walsh. But I would imagine the answer is yes. And is there a better way we can help streamline the system? Are people trying to do the right thing and just dropping off some of these PPE or some equipment to your hospitals? Are you just accepting them? Is there a better way we can help sort of get a clearinghouse for folks who may have found these in their basement or in their garage?
So you're both unmuted. You're both free to answer the question. This is to the nurses. Thank you.
So I don't have a drop-off box at Tufts, but certainly I can leave you my information. You can contact me, or we do have a command center at the hospital, so anybody could call and ask what they can do to, where they can donate, how they can do that. Because all the donations should go through our command center.
Excellent. And that's the same at St. Elizabeth's?
I agree with Mary. Yes, I think it would be helpful if donations came in through the command center. I would remind the public that we all donations will be accepted. Packages must be factory sealed and unused. For obvious reasons, we wouldn't want to use a box of masks that had already been exposed, that had already been opened. Would question any contaminants or exposure. We would we received an offer yesterday of a donation from an individual who wishes to remain private of $50,000 for frontline nurses and other healthcare workers, which the M&A has made a commitment to match.
That's great.
We will, and a couple of folks at the M&A are already working with a couple of different vendors to actually get that equipment in. At that point, we would, and I can't speak to this with any authority, but knowing the M&A the way I do, we would probably defer to somebody at the state level to determine allocation of those. But I can't imagine that there's not a need every place.
Yeah, I would just like to add, if I could, that any donations could be directed to the Massachusetts Nurses Association also, so that they could be dispersed statewide. And though we certainly appreciate individual donations, we too also received a wonderful donation, and said person wanted to remain anonymous, but a great thank you. The Massachusetts Nurses Association is working hard to try to provide the same protection to every healthcare worker across the state, not just the Mass Nurses Association affiliated hospitals.
Great. Thank you. And just thank you again to all of our panelists. Obviously, Ms. Sheridan, I know that we could spend hours on every topic, but the economic impact will be vast, will be significant. Mr. Antonellis, you do me proud. I had your job about 10 years ago. Keep up the good work, and my best to the men and women of the Suffolk County Sheriff's Department and all those who are in the Nashua Street Jail and Suffolk County House of Correction. Thank you, Mr. Chairman.
Thank you. So with that, I'm going to go to Council President Kim Janey. So the floor is yours. You're unmuted. Still present, Martha Sheridan, our two lovely nurses from St. Elizabeth's and Tufts, and Samuel Scarpino, as well as Peter Antonellis from the Suffolk Sheriff's Office.
I just want to thank each of you for the work that you're doing. A few questions. I wonder if I could start with Ms. Sheridan. Are you in conversation with BAA regarding the marathon being postponed till September 14th? And what are the plans around really using the marathon, assuming that we are out of this current state and that it's safe to kind of gather in crowds again by September 14th? How are you thinking we're using that to stimulate local business in the area, the same way that it does in April, but obviously, you know, folks are hurting in a different kind of way. So one, they're missing that April day, but now they're also missing a lot of other days in addition to Patriots Day. So I wonder about that. I wonder if you're in communication with the NAACP national branch and what the impact of the coronavirus has on the convention plans for July and what that means for tourism in the area. Maybe if we could just start with those two questions, that would be helpful to me.
Sure, happy to.
Thank you.
We work regularly with the BAA on the marathon, promoting it, assisting wherever necessary, and we'll certainly do that as well at this juncture. September is a little bit more of a busy time naturally in the city, so you know, we're hoping that we can maximize the experience for the runners that do come this year, and you know, we're hoping that we can generate as much interest and participation as in past years. So we will absolutely be working with them to maximize that event, and it will hopefully be a really nice time to remind us about the strength of this destination and how we can rebound. So we will certainly use that as an opportunity to do that. I am intimately involved with the NAACP convention. We are working closely with the local chapter and with the national chapter. At this point, we have not heard of any plans to cancel or scale back that event yet. Most of the events that we've heard of that are canceling or postponing are running up through mid-June. So we're still remaining hopeful that July is going to be a safe time to hold an event here. And in our business, we have something that we like to call pent-up demand, meaning that when a crisis is subsiding, the human spirit starts to crave old experiences and getting back out and being with people. So hopefully the timing on that will be just right. And we know obviously that the political environment will have a big impact on the attendance at that event, as well as it is an election year. So working very closely with all of those folks on every front. And I can't tell you how much we so want to make sure that this industry rebounds, because it's so important to the city of Boston and the entire Commonwealth.
Wonderful. I had just a few follow-up questions, if that's okay. I'm wondering, so a lot of us are trying to be creative. We're trying to think of new ways to engage the public, to continue on with our work, and to find some sense of normalcy. And there's this just a new normal now. And so I know, obviously we're doing this council hearing remotely is one example of that. I would imagine that our creative spaces, like our museums, are thinking of ways to bring the public in to their space, even though they can't do so, even though they can't do so physically. And so I wonder if you're having conversations with folks, with the museums around virtual bringing folks in, whether it's through film or some sort of exhibit, or what are ways that we can continue to, one, bring joy into the lives of people who many are feeling pent up, people are getting depressed, folks are overeating, we're sitting home, stockpile of food in our homes, and I'm guilty, so let me just say that. But I think the more we can bring folks through wonderful experiences, people may know that D Nice, who is a DJ, has been doing lives on Instagram, having these worldwide parties with 100,000 plus viewers. And so are the museums, through your conversations with them, doing something similar, thinking about ways to bring folks in?
They are. So many of the museums and attractions are doing virtual tours through their facilities or exhibits. And we do aggregate all that information and make it available on our website. We are also continuing to communicate with our vast databases via weekly e-blasts, as well as through our robust social media channels, where we feature many of these events, and also are working very closely with the restaurant community to encourage people to, in fact, take advantage of what they have available to them, so that, again, they can survive. So yes, we are continuing to be sensitive to the current situation, as we should be, but also trying to keep people interested in Boston and keeping residents interested and engaged in what we have to offer. And that'll be an evolving process for us. I think, as we all start to realize that this is not a 1 week or a 2 week situation now, we'll pivot our plans to make sure that in the long term, we are developing creative strategies to engage the community with our arts and cultural organizations and our small businesses.
Wonderful. And I wonder what ideas people are thinking about, or what opportunities are available in terms of connecting with some of the smaller businesses who are obviously hurting as well, and making them part of the solution as we're thinking about making Boston attractive to folks. And, I'm hopeful, given what I know about our city, that we will bounce back from this and we'll be stronger than ever when we do. And for me, Boston is always an attractive city, but I think during this time when we're kind of shut in, I wonder what ways we can engage small business in promoting how wonderful our city is. And I really think about small business in our neighborhoods. And so one conversation like I'd just love to have with you, regardless of whether we're talking about it in the context of the coronavirus, is really how we really elevate our neighborhoods and tell the story of our neighborhoods and help the neighborhoods contribute to the story of Boston. And so I wonder if there's an opportunity for small business to be part of the solution as you're thinking of ways to continue to tell the story of Boston, to keep people interested as we weather this storm.
So we are already very laser focused on promoting the neighborhoods of Boston. We have.
And Martha, could I also say, not just in terms of small business, but our local artists? Like, I think it's just real opportunity to take the local flavor that is in our neighborhoods and use that as part of how we get through this storm. And it helps promote them as well, because they're hurting as well. I'm sorry.
We have a page dedicated. We can't have one dedicated to every single nook and cranny neighborhood, but for instance, Jamaica Plain, Roxbury, Mattapan, we have pages dedicated to each of those neighborhoods on our website. And you have it up, thank you. And we right now are developing a series of 12 promotional videos for each neighborhood, which is obviously on hold for a bit, but we do have our Jamaica Plain video up and posted on our website, and we'll use those videos both in long form and short form to promote the area. And our goal has always been to take advantage of the critical mass of visitors that are right in the central core and maybe alleviate some of the pressure on the central core. We know that Chinatown and the North End and Back Bay are already drawing huge numbers of visitors under normal circumstances, and we want those visitors to experience every corner. So we are developing a sort of live like a local campaign that we will continue to evolve. Right now in the slow time, we aggregate social media posts from each of those neighborhoods so that you can see what people are posting about the small businesses in those areas. And the formats of our videos are very much focused on the artists and the small businesses within those communities as well. So that's a great question. And now more than ever, we want to make sure we put that program on steroids to make it even more meaningful. And we hope that the program actually has almost an inverse effect. It gets people and visitors into the neighborhoods and residents that may not have been there before to experience what the neighborhoods have, but then it shows those neighborhoods that they can in fact become viable tourism destinations and visitor destinations, and allows them to think more critically about their assets and how do they promote themselves as part of this big tourism ecosystem in the city of Boston.
Thank you. I have additional questions, but I'll defer to the second round. I know my colleagues are very anxious to get in. Thank you, Mr. Chair.
Thank you, President Janney. Just really quickly, we have another guest. I just need to see who this is really quickly. 1 second. Rob. Hello.
Hey, what's going on?
Which Rob is this?
This is Rob from the I don't know, just the concerned citizen.
Okay, so you're for public comment. Okay, I just want to make sure. Okay, great. So just hang out. We'll get to you. Thank you for checking.
Yeah.
Okay, so with that, Councilor Mejia, if I could just give you the floor. So you have 5 minutes. We got Peter Antonellis, the sheriff's office here. We got Samuel Scarpino from Emergent Labs. We got Martha Sheridan.
I'm not going to take up 5 minutes. Thank you. I'll be really brief. Curious about when we have nurses that show up to work, and because we have limited testing kits available, how are the nurses determining whether or not they're going to be showing up to work? Is this something that when they arrive at work, you assess them and then let them work? Like, I'm just curious about how that is looking in the hospitals?
So we have specific guidelines at Tufts, and they are following the DPH and CDC recommendations. And of course, there's a lot of controversy over it, but currently, if you are symptom-free, then you are to report to work. If you have sustained an exposure and were notified, or even if you weren't, you just assumed that you might have been exposed, as long as you're asymptomatic, we are expected to work. If you have been exposed, whether you are confirming it as a community exposure that you know for sure the person that you were exposed to was tested positive, or if it's a work-related exposure, if you are asymptomatic, you can work and you need to wear a mask. But the moment you become symptomatic, you are going to be tested and sent home. So that's based on guidelines. You know, it's not comforting really for anybody, for us, or for limiting exposure. Because as you've heard many times, the fact is that some people don't present with symptoms, yet they're still positive, and we're just not doing broad-based testing enough to know that and to stop the spread that way. But precautions are being taken in terms of any symptomatology.
And then, thank you for that. And then my other question is in regards to the social and emotional well-being, specifically around the mental health aspects, in terms of the type of, if any, services that the nurses are getting or should be getting that we should be mindful of in terms of our advocacy efforts. Like, how is this taking an emotional toll on your
It's pretty devastating, and we haven't even seen the worst of it. I mean, most of it is at this time fear and anxiety of the unknown, and of the most of the anxiety is produced around the fact that we're sure there's not enough personal protection equipment for us. I know Tufts is offering, we have a robust employee assistant program, and they've extended their hours, have people on site, offer telecounseling. Our insurance companies, we have 2 plans that nurses can pick from, and they both have okayed telecounseling coverage. So, and I know there are some individuals, like within my own nursing community, that have gone out on their own to provide like stress relief and resiliency training for nurses in this time.
Thank you. And then one last question, Councilor Arroyo, can you just give me a time check? What's my?
You're good. You can ask questions.
Okay, so I'm just curious in terms of, I've heard from a lot of people that they have gone to hospitals and have been turned away because they don't fit within a specific criteria in terms of getting testing. Where are they being referred to? Are they told to go to a local community health center? How are they being sent back into the community?
I have no knowledge of anybody being turned away from testing. Anybody who meets any of the criteria has been tested. Up until last week, the turnaround time for a test was 10 days. Beginning this week, it's down to about 4 days. The message here is, even if somebody doesn't meet the criteria, and it's a fairly lax set of criteria, we all need to be doing the same thing. So a positive test or a negative test result should not change one's behavior. And that is, we need to follow all the guidelines, social distancing, and frankly, coming to the hospital is probably not a great idea. We do have a lot of worried well. We have people who just want to be told that they're negative, and that their lives will be minimally impacted by this. And frankly, a negative test result shouldn't change life all that much for anybody. We all need to continue doing the same things. And I'd just like to make one observation. I've seen everybody on this screen touch their faces more than once while we're on. We all need to pretend that we're wearing big Elizabethan ruffs or something like that. Keep your hands below your shoulders. That would help us all immensely.
Okay, well, I got that note because I know I was up in my face the whole entire time. And so, yeah, I just wanted to flag for our my colleagues is that I've heard from some folks out in the community that they have tried to get testing and because they didn't meet a criteria, they were turned away. So just wanted to flag that. And the last question is on the business side. In regards to, I mean, I'm always all about trying to find the silver lining and the blessing in disguise here in terms of how we can do business differently in the city of Boston. So I think that the coronavirus is really pushing us in that direction. I'm just curious as to how are you, this question is for Miriam, I believe, Martha, in regards to how are you repurposing workers who are showing up, who can still work in the hotel industry? What type of work are they doing in those spaces?
Honestly, I don't think there are many showing up anymore. I have to be totally honest. Every day the list of hotel closures grows. And at this point, there's just not much available in the service sector for these wonderful frontline employees that we care deeply about. So our hope is that we can get some relief in the form of some stimulus from the federal government that will help sustain them with some direct payroll benefits. But at this point, given the state of the shutdown, so to speak, it's just not feasible that we're able to position them in other jobs right now.
Thank you. Thank you. Thank you, Councilor Arroyo, for giving me the opportunity to ask questions, and I'll defer to the next round when there's another opportunity. Thank you.
Thank you.
Well, thank you all.
Councilor Braden, I'm heading to you. Let me just unmute you there. There you go. Any questions you have for folks here?
I've had some inquiries about how can retired healthcare professionals contact the M&A to help in any capacity, and who is there a contact point?
Our website is massnurses.org.
Okay.
And there are membership specialists, and I do. Mary, who else would be a good person?
They can just call they can call the main number and ask, and they can be redirected, through dialing the number there.
Okay, so you folks might have ideas how people could support work and in a more step away from the front line necessary, probably, but to support the folks at the front line.
There probably are a variety of things that I personally am not organizing things. I know that at Tufts, several retired RNs have reached out to me. I've asked them to touch base with their colleagues, their former colleagues on their units that they used to work on, and ask if there's anything they can do individually. And I will look to my chief nursing officer to see if there's a way we can utilize those nurses that want to return. They probably won't be frontline depending on how long they've been away from practice, but I'm sure there are a multitude of other ways that they can help facilitate what we're trying to deal with in the hospitals.
Very good, thank you. The other question I had was with regard to nurses who are exposed to a case in the course of your duties, and if you're asymptomatic, even though you might be a carrier at that stage, you're still expected to be in the workforce and go back to work.
That is correct. At Tufts, we have a strict criteria, and it depends on the amount of exposure and the type of exposure that you might have had to either a case or a coworker. I don't have those specifics in front of me, but it's very clearly defined. And so whatever category you fall into, that's based on how you respond to whether or not you should work or whether or not you should be quarantined.
So in the case of being quarantined, are you supposed to go to your own home and be quarantined? Or I heard of someone who was basically in their RV or camping out in their
Yeah.
garage as a way to keep them away from their family, intergenerational
So,
family.
yeah, we don't have anything specific. We've asked nurses to be creative in their own homes, and many of us have. I know I have a separate room, so I don't expose myself to my husband. And a lot of nurses are doing that. They're, in fact, just doing it preemptively. The children have been sent to stay with, say, grandparents or some other family member that can care for them during this time to limit that kind of exposure. But segregating ourselves within our own households, and most of us are pretty hyper when it comes to cleaning. So, just following those kind of steps are what we were doing currently. There has been some discussion, nothing definitive in terms of making arrangements for areas for quarantining, like Tufts University has released rooms to be used for either staff or perhaps down the line creating hospital beds for quarantine patients. Like we are looking into some more creative ways to quarantine, depending on how much of that population explodes when the time comes.
So
I do know of a member of the senior leadership team who sent her young adult son to away to a bed and breakfast because she had another child who actually tested positive. And she's in work wearing a mask. So she's had a significant exposure. She lives with somebody who has had a confirmed positive, and she's asymptomatic. So she is in work and she is wearing a mask. I do know of a nurse who has sent her 7-year-old child away with relatives for the duration. And I know of somebody else who commandeered her teenage son's vehicle. And she's using that exclusively, but she's not contaminating the family vehicle. We're getting pretty creative, and we're thinking beyond the first, second, and third steps in an effort to curtail this and to raise the consciousness of people, to get people thinking about what we need to do to stop this. I think that the thing that's really impacted nurses is a lot of us we're frightened, and it's a little bit lonely sometimes, as we want to we want to show our families and our loved ones just how much we love them by removing ourselves from their lives. I have to say, one of the things that's been really tough in the front line and at the hospital is separating patients from their visitors.
Yeah.
There's a no visitor policy except within a couple of very specific circumstances, and that's been a hardship. It's very difficult for families to separate from a loved one, and it's very difficult for the patients. If I could, I would like to have more nurses on the front line to spend more time with those patients who aren't receiving companionship and care from their families.
I'd like to jump in here too, and I don't want to turn this into a political discussion, but we fought long and hard to get question 1 passed to provide adequate staffing in all of the facilities across the state. And unfortunately, we lost. And unfortunately, that could be a consequence in this situation, because even on a good day, many facilities do not have adequate staffing. And now we're facing this pandemic and an influx of, a tidal wave of numbers of patients. And we're going to be scrambling to try to find coverage for each and every bed. We are getting creative in terms of moving nurses out of procedural areas and into bedside units to, assist at least with patient care assignments. But, I know it may feel uncomfortable in terms of how we're practicing the exposure, symptomatic versus asymptomatic, and having nurses work. But to minus out anybody that was potentially exposed and is not yet positive, you're going to be subtracting a large part of the workforce. and that will create additional problems. So we're walking a very fine line here. You know, we can't afford to not have nurses at work, yet how bad is this going to be? So,
and this is going to be a case of nurses have too many patients to care for. So once a patient is in the hospital, the nurse is caring for that patient. The moment that's most unsafe, the moment that a nurse is most likely to be exposed to coronavirus, is when they're doffing, that is, they're removing their PPE. And if I'm taking care of 5 patients and I'm doffing equipment 5 times a day, that's 5 at a minimum, or doffing once for each patient, that's a significant amount of exposure. If we were taking care of fewer patients, if the hospitals were staffing up with nurses so that we didn't have to take care of so many patients, we could maybe avoid or lower the risk. And if we weren't so rushed, there is just no time to provide the care we need. And now the donning and doffing process it can take several minutes for each patient. One of the benefits of the drive-in test center is that you avoid that. The drive-in test center, when people stay in their cars, the only thing the tester needs to change is gloves. The tester can stay in the same hood and gown. When people come to the hospital and they want to be tested individually, it's donning and doffing for each patient, and it's using up tremendous resources. I think we could make those resources last longer if we were doing more drive-up testing.
Yeah. I think to your point about staffing, I think in the Berkshire Medical Center, they had exposure out there, and the staff were all put out into
that's correct. Yes,
and
they
bring in
they brought in travelers to cover the regular core staff vacancies. Yeah.
Okay. I had another question about the level of acuity in terms of how are you finding the numbers of patients who come in? Are they very sick? Do they need intensive care, or are you able to manage them on a regular floor? Or how are you managing that?
So we at Tufts have cohorted 2 separate areas right now, and we're working on additional areas. We've converted 2 units into 1 large intensive care unit area for COVID positive patients. And we also have redirected 1 floor for not so acutely ill COVID positive patients. And we're currently working to create more intensive care unit beds in other areas of the hospital. I'm not sure of the numbers, so please don't quote me on this, but the ICU patients that we've had have not been, they haven't died. Let's just say that. You know, they're sick. They're sick, and obviously are in an ICU for a reason. But we haven't lost anybody at Tufts yet to COVID.
Thank you. There was one more question. What was it? Oh yes, as a healthcare professional, just the point I think you've been saying this, Ellen, and is you should assume everyone is infected. And you should try and observe, like take universal precautions, just assume everybody you meet in your life is infected, or that you're infected and everybody that you meet is potentially going to be infected from you. So I think washing our hands, trying to keep our hands away from our faces is really important. But thank you so much for your incredible work. And I'm really, really deeply appreciative of all the work that the nurses are doing. And, you know, happy to, please let us know if we can be of any assistance. Thank you.
Thank you. Thank you very much.
Thank you so much. Thank you for your support.
You're welcome.
I think you're still
Counselor,
muted.
yeah,
Mr.
I was
Chairman.
muted. Councillor Flynn, you now have the floor. Sorry about that. Councillor Flynn, you have the floor.
Thank you, Councilor Arroyo, and to all the panelists that are here. It's been an excellent, informative conversation. probably the highlight of being on the city council is the work, I think, in my opinion, that we've done working closely with our nurses across the state, and including Mass Nurses Association. They're really on the front lines, and they're willing to almost risk their health for the safety of the safety of the public. So we have great respect and admiration for our nurses. I'm also concerned. I had the opportunity, as many of you know, to have served overseas, and I'm part of this Gulf War registry. That if you've been exposed to different toxins in that area, but I feel the same way about our nurses, what the short-term health concerns are, but also the long-term health concerns are for our nurses and their families. So I think this is something that we really have to focus on as a city council and as a city, to make sure that our nurses not only have the protection now, but long-term, we need to make sure that we follow up and make sure that we do a complete study on their overall health as well, because I have some significant concerns about that, and I just wanted to ask the nurses if they also feel that same way.
Absolutely. I think, the biggest worry is long-term respiratory compromise, since that's what's killing patients. And even if you survive, you probably sustain some damage to your lungs, which would then lead you to be, open to other respiratory problems in the years to come. There'll obviously need to be a lot of tracking about that. I rely on our esteemed colleague at Harvard, Dr. Lipsitch. I'm sure that studies will be going out about that. And also Harvard does a long-term nursing survey yearly, which they've been doing for more than 30 years now. And I'm sure they'll add that to their questionnaire. But yeah, the respiratory compromise is going to be the biggest issue, I think, in terms of physical damage done. And of course, there's the emotional trauma of what we were about to sustain in our daily work lives.
I predict that there will be a post-corona respiratory syndrome based on what I've seen, the x-rays of patients who are, and the CAT scans of patients who are positive. There is a significant lung involvement. It almost looks like a something that, like an odds, an adult respiratory distress syndrome, which is frequently the result of a battle wound or some sort of horrific trauma. The lungs are just that impacted by this. I can't imagine that in the years to come, we won't see fallout from this. And as far as the trauma to nurses, it's not just, the majority of us are nurses, but we also have nursing assistants and techs and the respiratory therapists who will be stretched so thin. I think that we will end up dividing our lives into pre-corona and post-corona. I think it will be that impact.
Yeah, I've already started calling it BC, before corona and after. Yeah.
BC and AC.
BC
yes.
and AC.
This will be a defining moment.
It is.
I think it's important, it's critical for our colleges and universities that aren't using their dorms, but also the hospitals that aren't, the hotels that aren't using their rooms. I think it's important that they step forward and provide rooms for our medical professionals, our nurses, so that they can quarantine, at least have the ability to quarantine away from their families, so that they're not subjecting their children or their spouse to this. But I know there's ongoing discussions about that now, and there's some elected officials that are very dedicated to making sure that that does happen. But thank you to the leadership of our MNA. Thank you to the leadership of our nurses and other medical professionals for what you're doing, really saving so many lives in our city and putting your whole career and your whole health on the line for other people to live. So we owe
Thank you.
you. We owe
Thank
you
you for that,
Thank you.
Thank you, Councilor Flynn, and thank you for your service.
Thank you.
I know that nurses have looked into booking hotel rooms locally in order to stay away from their families. That becomes quite pricey and absolutely out of the reach of anybody who's in any of the techs or nursing assistants. Financially, they couldn't possibly hope to afford to rent a hotel room in Boston.
Yeah, I would think that the hotels and the colleges and universities, those rooms, in my opinion, should be free for our medical personnel, so that they could stay there in quarantine. But I know there's further discussions that continues to take place, but that's something we are going to be staying on top of, working closely with M&A as well.
Oh, that would be great.
That'd be great. Yeah, that would be wonderful.
Yeah, that would go a long way.
Thank you. Thank you for all that you're doing for us, Councilor Flynn. We really appreciate it.
Thank you.
Councilor Flynn, is that it for your questions here?
Yes, that's it, Councilor Arroyo.
Thank you. Councilor Sabi George, do you have any questions? No? Thank you. I believe that leaves me before we go into the second round. I again want to thank everybody for their participation. I'm going to go ahead and try and structure this in a way. So my first question for our two nurses, I know there's been some conversation. We just talked about the housing situation with hotels possibly as a solution. But in terms of parking, a lot of folks are having to park and maybe having to pay for parking. Are there any places where we can try to use our municipal capital to try and push folks to do the right thing here? I think, which would be to reduce rates, or to frankly preferably have no rates for our frontline medical staff. Is there any place where that's currently being provided that you're aware of, or places where that should be provided?
We've made some adjustments at Tufts. Those people that were taking public transportation and had, a valid T-Pass can now park in the closest parking lot. And our hospital's been very good about that. They've made allocations. We do have 3 employee parking lots that are within, 2 blocks. So they also run a shuttle service, and we do need to adjust that. It would be wonderful if parking could be reduced. I know as a night shift worker myself, my parking is fairly minimal, but the day and evening shift people are paying a little bit more of a premium price, and that really should be eradicated, and we should all be allowed to park in, a closer garage.
I would like to see every frontline care provider off of shuttle buses. I think whatever facilities have to do to make it so that anybody providing direct care can park on the property or very, very close to the property. And I don't think any of us providing direct care should bear the burden of that shift.
I agree with you both.
The financial burden of that shift. I think that should come at no cost.
And so I've been told that Beth Israel is allowing folks to park for free, but I think where and when you hear of places that aren't necessarily doing that for our frontline workers, please do bring that to our attention, and we'll reach out to those organizations, because it's vitally important that you be freed up to do the work you have to do.
Thank you.
If I can go to Sam Scarpino or Samuel Scarpino, I don't know which one you prefer. There you go. You're unmuted. Is Sam or Samuel, which is the preference?
Either one is just fine. Thank you.
So one of the things that you spoke about, which I thought was very interesting, not here, but in the press, you were asked a question about this, and you brought up maybe tracking through apps, maybe creating an application to track folks as a way to also track breakouts, and to do so in a way that's maybe less authoritarian or big brothery. is there any work being done on that? Is there anything you can add on kind of what your idea there is and how you would see that work?
There are a number of groups that are actively researching how we might better leverage mobile applications and mobility data on individuals to better understand the progression of the outbreak, but also monitor individuals as they either progress through symptoms or receive a negative test result. You know, one of the biggest challenges that we have right now is just really understanding the total burden of individuals that are maybe currently in the exposed portion of dealing with the COVID infection and may show up to the hospitals, you know, over the next week to 2 weeks. And that information is obviously of vital importance for the individuals who are planning the hospital response, but also for the individuals who are thinking about the next weeks and months as we need to strategize around the economic effects of this outbreak. And so there should be ways that we can leverage data coming from individuals either through smartphone applications or other sources that doesn't require individuals giving up their privacy. I think there's a way that we can be smart about it and balance the important privacy rights that we all have in the United States with the need to capture vital information for our public health officials. So that is a very active area of research, but I think it's a conversation that individuals like yourselves are going to need to be actively involved in. How do we balance the critical privacy rights with the public health need and the need to protect our frontline healthcare workers? So I think this is a conversation that we need to be having both as a society and amongst our leaders right away.
And so just as a follow-up on that, as we deal with this pandemic, it is emergent in terms of its size and scope. Every day it's moving and it's doing different things and it's growing seemingly by the day. How quickly could, if we were able to mobilize on some kind of creation of an app to essentially track, where outbreaks are happening and to have folks self-monitor in a way that maybe takes pressure off of our healthcare systems, how quickly do you think from a technical side an app like that could be up and running?
I think technically it could be done very quickly. I mean, in terms of the types of things we would need to do, it's relatively simple from the technology perspective. And we're, of course, fortunate to be in Boston. We have some of the leading privacy experts and health privacy experts in the world to help us think through all of the gotchas that are going to be associated with gathering that kind of information and being sure that we don't expose anyone's personal information. So I think it's something that we should definitely be seriously considering as a part of our response to this outbreak. I will say that, of course, one of the big challenges is we still don't know the full burden of the outbreak, not even close. And because it takes so long for individuals to both show symptoms, but then as we're hearing from our nurses, progress in the symptom severity, that the peak in the hospitalization demand, the peak in the ICU demand, and unfortunately the peak in mortality is going to be weeks and weeks after the cases spike. So everything we're doing today, it's not for the cases tomorrow. The die has already been cast for those cases. It's the cases that are going to happen, weeks from now, which is why individuals need to take the self-isolation seriously. I mean, seeing individuals like our political leaders in Washington going to the gym while they're waiting on a positive test result is beyond reckless. And so we need to do things to really ensure that individuals that might have been exposed are self-isolating so that we can stop this outbreak from continuing to grow exponentially fast.
And so then I have two more questions. One is definitely for you. The other one may be for you and may be for our nurses. I know you've created a model of the coronavirus in comparison to how it's growing in Massachusetts as opposed to South Korea or China or Italy. I'm curious as to what that model is informing you and how that might inform some of our decision making.
Well, one of the the unfortunate parts about the course of this outbreak is that you really don't need a model to look at the trajectory. So it doubles consistently every 2 to 5 days until we intervene. And those interventions really mean restricting mobility, self-isolation, high rates of testing, protecting our frontline healthcare workers. Until those things go in place, this just doubles like clockwork, grows exponentially fast. And so we're really still in that phase. We are ahead with respect to what Boston is doing, what Massachusetts is doing, but those measures really were only put in place about a week ago, and it's going to take another week or two before we start to see the payoff, which means that we're going to have to keep these measures in place, and that's going to be hard. And so we need to make sure that we're providing for our individuals that are at risk in the population, the individuals that are going to be bearing the burden of the Flatten the Curve initiative. But what the models do tell us, and what we see in South Korea and other places, is that they work. And so if you implement these kinds of measures, they work to bring down the number of cases, they work to bring down the peak demand on the hospitals, and at least give our healthcare workers as much of a chance as possible to save lives and protect themselves. And so we really need to take this very, very seriously while balancing the very, very serious economic effects that we've also heard of.
And so thank you for that. That's enlightening. I think for this next question, which is a follow-up to that, it's open to both our registered nurses and to you, Mr. Scarpino. I noticed in LA recently they've stopped essentially testing. They've gone away from containment more towards mitigation. My questions here as a layperson, if we are not accurately testing, which by all reports we're not, in the sense that we don't have enough tests to essentially, and we don't have enough time in between those tests to really get a scope of the problem, or a general scope of the problem, at what point should we be making decisions based more on mitigation as opposed to containment? Or are those things always capable of being done even without proper testing?
So I've always thought that whether one tests negative or positive, the behavior should be the change, unless and until there's a definitive treatment where we can say this will shorten the impact or diminish the impact of the illness. Unless and until we have something that can do that, testing doesn't change anything. We all still need to behave as if we're infected. We all still need to follow the best practices for minimizing exposure and minimizing transference. Even if you test negative today, and by virtue of any test, there will be false negatives. Even if somebody tests negative today, they could test positive tomorrow. The behavior should never, ever change, and the treatment should never, ever change, unless and until, again, as I said, unless and until there is a definitive treatment. We should consider everybody positive all the time.
And so
a negative test could actually give somebody a false sense of
security,
of security, and thinking that they've dodged that bullet,
right?
When that's not true.
So essentially what I'm hearing from our medical professionals is make sure you continue to self-isolate, make sure you continue to physically distance, regardless of what you believe your test results may be, regardless of what your test results are, if they're negative, that the best thing that anybody can do in this situation, if they want to help our frontline workers, if they want to help the rest of us with the pandemic in terms of controlling this pandemic, is to self-isolate and to essentially physically distance themselves continuously.
That's correct.
Yes, absolutely accurate.
I appreciate that.
For what it's worth, I completely agree. And my perspective is one thinking about the testing we're going to need as we move forward from this. And so everyone absolutely, especially given the potential for pre-symptomatic transmission, that you're essentially, and of course this is just me speaking as a concerned citizen now, you're essentially putting the public at risk and disrespecting the sacrifice that our frontline workers are making by not taking this seriously.
And then one follow-up to Mr. Scarpino before I head to Mr. Antonellis. You mentioned that where we are right now, we're trying to deal with folks that are coming in the door right now. We're not necessarily looking at folks that are going to be coming in 2 to 3 weeks. And so if you could just give me some some background as to what you mean by that, and some things that we can be thinking about, forward thinking as city leaders, on ways that we can try and get ahead of something that so far has been it's forced a lot of reaction rather than proactive action. And so anything that you can suggest here from what your model suggests or what has worked in other places.
Absolutely. So the average time from exposure to symptom onset is 5 days. It can be as long as 14 days, which is where that 2-week isolation comes from. Most of the hospitalization time can be, weeks long, and gets much longer if the individual ends up going through a severe set of symptoms. And so the individuals that are coming into our hospitals today were probably exposed a week ago or more to the infection. In addition, when we see these confirmed test results, oftentimes what happens is that they'll be presumptive positive by having a test at a healthcare facility and then confirmed by the CDC. And that means that these confirmed case counts could be, days or possibly weeks old in terms of the total case burden that's out there. So we really need to be thinking about what's going to happen a week from now, 2 weeks from now, as you said, to stop being so reactive. My position and what we see in the models is that individuals need to mobilize in a way that we have really not mobilized for something in most of our lifetimes. I think we have the capacity in this country to provide the manufacturing of personal protective equipment, of masks, of ventilators, to make the facilities available. Staffing is going to be a huge issue, and obviously we can't train nurses and professional healthcare workers over the time course of this outbreak, but there are plenty of other roles that provide essential services that we can train people for. And all of these things, if we're not starting to do them today, it's just going to be that much worse when we start doing them. And so I think to the extent that we can mobilize, we can find ways to get people to work that are out of a job and looking for a job, leverage money coming hopefully from the federal government. I think we have to be doing that right now, because this is just going to keep getting worse. Even now we put in the measures in place, it's going to be a few weeks before we see things start to slow down, and many, many, many weeks after that before we're anywhere back to normal with respect to the hospital burden.
I appreciate that. I appreciate your answer. Mr. Antonellis, are you there?
I'm here. Yep, I'm still here.
So one of the questions I had for you is, you said you're taking the temperatures on inmates who are incoming and visitors?
Everyone.
So
Staff.
that includes employees, that includes folks that are already in the facility?
Anyone entering the facility, whether they be inmate or staff. So if you're coming through a sally port or you're coming through the front door, everyone's getting a temperature screen.
Okay, and so what happens if somebody does have fevers or symptoms? What's the protocol for containment there? Or if they're coming in, what's the protocol?
Right, my understanding is that staff coming in, if their temperature is beyond the limit that we've set, they are being refused entry to the facility and asked to return home, work from home if appropriate, until their fever subsides. If an inmate coming into the facility has a fever or is exhibiting symptoms, again, my understanding is that we are setting up space within the facility to isolate those individuals so they're not entering general population.
And do you know where? So, for instance, a lot of folks, especially at Suffolk County, are pre-trial detainees. And so if they're being sent to the facility, you're saying that basically the facility is not refusing them, but they have a space where they're kind of isolating them?
That is my understanding, Counselor. And if I learn that I have misspoke or mischaracterized, I will, of course, clarify that with the entire council. But that, as I said, that is my understanding. We're not refusing anyone. We are designating space not only for anyone coming in with symptoms, but if anyone starts to exhibit within the population. But as I said earlier, at this point, I have no knowledge of any COVID-19 confirmed cases within the facilities.
Thank you. And then one other thing that I know concerns me is a lot of these folks are being restricted in their visitation, correct? There's crackdown, essentially. There's less visitation happening between folks on the outside other than essential visitation from attorneys.
Yes, the sheriff implemented that policy, I believe, 2 weeks ago. The only visitations inmates are allowed at the moment are from their attorneys and clergy, and those meetings are being held behind glass in an effort to stop the infection from reaching the inmates directly. At the House of Corrections, for example, we have a contact visitation area. Traditionally, where appropriate, inmates would be able to interact with their visitors. We have had to stop that, but as a means of mitigating it, as I said, we are offering free phone calls twice a week, because we know that visitation is such a crucial part of the rehabilitation process. It's so much more helpful when inmates have that connection on the outside, that they have someone to talk to, something to strive to. And we took that, we made that decision. The sheriff made that decision. It was a very difficult decision to make, but the health of the inmates in those working in the facility had to, we have to prioritize right now, as difficult it is. And so I said, we are doing the free phone calls. We are trying to expand that service because we know that visitation and contact with family and friends and those on the outside is so critical.
Thank you for that answer. And then in terms of, I know that the sheriff has announced that they were, I think, trying to up the amount of video visitation that they have capacity to do.
Yes, we do have video capacity. We've been, kind of evolving with criminal justice, as the whole industry has been going, sort of, kind of using video and instead of like transporting people to court for hearings and so forth, could we do video? So that technology is there. And yes, we have been trying to use that technology to expand access for the inmates to connect with people on the outside. And I will confirm with the sheriff those efforts, and I'm happy to report back.
Thank you. I appreciate that. And I appreciate the efforts you're taking to maintain the safety of staff and the folks in your custody. At this time, I'm going to take a quick look at who we still have online. Does anybody have any questions for round two? You just raise your hand if you do, and I'll send you. I'm not seeing any hands. So with that, I'm going to go ahead and put this into recess. I do want to note that we had invited representatives for the hospitals, community health centers, and for the administration. Obviously, with the way things are progressing day by day, they have very hard work on their hands. They're dealing with things that are happening as we speak. The secure in place went into the advisory for secure in place went into place today. The goal and intention, I believe, they will be participating in future hearings that we conduct in this way. I appreciate everybody who's able to do this. I appreciate those that weren't able to do this because they're out doing the work on the front lines as we speak, a number of doctors. And so I just want to say that I'm grateful for your participation in this new medium. I'm not sure we've done this before. I would tell my colleagues that this has actually been easier, I would say, than perhaps I would have thought it would have been to navigate something like this. Perhaps we should elect more millennials. This is working pretty well. And on that note, I'm going to recess to a date to be decided when we can have more folks present from the city and from our local hospitals and community health centers. I want to also announce that we'll be doing public comment. We're going to try and do public comment through this medium. And so we'll stay open for another 15 minutes after this to allow folks to kind of come online and do this. I also want to give a shout out to Carrie Jordan, who's been doing the work behind the scenes to really make sure that this works. So thank you to you, sir, and the rest of our staff and colleagues who've come through in this way. I also want to make sure that folks who are listening, if you feel like you have some symptoms or you have questions, you're asked to call 311 if you reside in Boston, 211 for the rest of the state. And then we also have, just since we have you here, if I can pull this out, if you can text hold on one second. We have a text system for folks as they look for details to be communicated to them. as this is ongoing. If you can text BOSS COVID, which is BOSCOVID, to 99411, you'll get updates as they progress from the city of Boston on things as they're going. So with that, I'm going to recess this to a period in the future, and I'm just going to stay open for 15 minutes here for public comment. Councilor Flynn, do you have something? Do you want to participate real quick? Hold on. Councilor Flynn?
Yeah, just briefly, Councilor Arroyo, during this crisis, I just wanted to highlight it's also critical. We continue to come together as a city and especially treat our immigrant neighbors with dignity and respect and empathy. This is a time for bringing people together. It's not a time of division, and it's critical that we don't blame anybody for this epidemic that's taking place in our country. I have a proud and great relationship with the Chinese community in our city, but I'm also unfortunately seeing a lot of anti-Chinese sentiment happening across the country, anti-Asian sentiment, discrimination, racism across the country. So as a country, we need to make sure we treat everybody with dignity, respect, empathy, and love. That's my final comment. And again, just want to say thank you, Councilor Arroyo.
Thank you. And actually, on that note, this is a different medium for me. It's also my first hearing. If any councilor would like to say a closing statement, please do raise your hand and I'll make sure I get to you. Councilor O'Malley, I'm going to go to you first.
Thank you. Not so much as a closing statement as much as I believe for public testimony, we need to quit this meeting and then I'll log on to another one with a different ID and password.
I appreciate that. Thank you for that. Councilor Mejia. Oh, hold on. You're muted. There you go.
Councilor Arroyo, just for clarity's sakes, it sounds like we're going to be moving on to a different part of the hearing. So we're going to be going into public hearing. So are we going to, do we have to log on to, I think Matt just said we have to go somewhere else. You said a recess for 15 minutes. Do we have a 15-minute break and then we come back?
So let me get into that. So what I'm saying is I'm gonna give us 15 minutes. It's 4:22. I'm gonna give everybody 15 minutes to get into that room, and then we'll go from there once this meeting is adjourned.
Okay. Got it. Okay.
And so that's already out there. It's in the email.
Yeah.
Link to,
I
okay,
want to make sure that I'm going to be transitioning somewhere else, and if I go, I know how to get there. But just wanted to say thank you to both of the nurses who participated. You know, I know that you guys are on the front lines doing this work every day, and just know that we're always here to not only just support your work, but understand that we as the city council have an opportunity and a responsibility to advocate for the things that you're not getting. So continue to rely on us for such. So I just wanted to say thank you both for your continued work on behalf of our most vulnerable populations. And I really do appreciate everything that you have done and continue to do to serve our community. So thank you for that. And then if we're going to do closing remarks, I just wanted to give a shout out to Councilor Arroyo for hosting his first hearing and doing so under these circumstances. You've done an amazing job at keeping the conversation going. And I work with energy, and even though I couldn't feel people's energy, I could still see it. And so I just wanted to thank everyone for being so engaged in this process. It was very informative. I've learned a lot, and the voice that I always bring into the space are the voices of the people who are never in these situations. So I may not always have the right terminology, I may not know how to say things the way, you know, we're supposed to say them, but I just wanted to just say thank you for keeping us on track and keeping us going and creating an opportunity for people to ask these questions. So good job and keep it up.
Thank you, and I hope the rest of you see that this is a viable way to do this. I'm gonna go to President Janey. You got the floor.
Hey, so I want to ditto. I want to echo what Councilor Mejia just said. First, let me just thank all of the panelists. I think all of you were very informative. Many of you are on the front lines. I appreciate the work that you do. We are here for you. Whatever movement folks want to do, I'm sure all of my colleagues would want to sign on to all of the efforts to support the work that you're doing. Certainly want to thank the makers of this hearing order. Thank you. This is a very important conversation. Thank everyone for staying engaged for, here we are, 4:25 for a 1 o'clock hearing. And then Councilor Arroyo, just spectacular. As Councilor Mejia just said, your very first hearing, and it's the very first virtual hearing that we're holding as a council. So baptism by fire, you did a wonderful job. This, gives us hope because this allows us to bring more people in and makes our work more accessible. And so I'm excited to get into the next chat room, I guess it is, and hoping that I can follow the instructions too. But thanks to everyone for a wonderful conversation.
Thank you. Councilor Braden.
I just quickly wanted to say thank you so much to everyone who participated. Thank you, Councillor Arroyo. Spectacular hearing. It was wonderful to bring all these people together and have this conversation. It's very necessary. And for the nurses and the doctors and all the frontline folks, stay safe, be well, and please let us know if there's anything we can do to help. Thank you.
Thank you so much.
Thank you. Thank you so much.
Councilor Wu, you have the floor.
Thank you. I just want to echo the incredible panelists in all of the recommendations that you've laid out. We'll work our hardest to follow it up with policy. Thank you especially to those on the front lines and to our nurses for taking the time, to our epidemiologists and others. We've learned a lot, and looking forward to keeping the conversation going. Thank you, Mr. Chairman. You did an incredible job, and it's been fun to partner on this with you. Thank you.
Thank you. And so with that, I see that Rob is here. Rob is public comment. And so because Rob's here, I'm going to take his 2 minutes here. And then I'm going to recess. We're going to head over to the community center, community comment, public comment section, which is a separate Zoom video to try and manage the way that this gets done. And then from there, we'll recess this and we'll have an additional hearing in the future to track sort of developments and have more folks at the table. Thank you everybody for participating. And let me just give Rob the floor. Rob, you have 2 minutes. You there, Rob?
Yeah, I'm here. No, I just wanted to just thank the council for having this meeting. I think it's very informative. I'm looking forward to other meetings in the future, and just thanks again.
I appreciate you for your civic engagement, Rob. Thank you.
Mm-hmm.
And so on that note, we're going to head over to the other Zoom chat. If, for the counselors, that's on the email that was sent out. Same thing for our panelists who are still here. There's an email there. It has 2 separate ones. So now we're going to the other one. I'm going to do a 15-minute recess. So I will be there at, it's 4:28. So let's say 4:45, and then we can get everything up and running. Sound good? All right. See y'all there. All right, everybody. I think we're ready to start with the public comment here. I know Kerry Jordan is helping me with this just to make sure that only folks who are here for public comment essentially get called on. I'm going to give 2 minutes to folks, and I'm going to keep you to that 2 minutes. I'm going to have a timer going. I appreciate folks chiming in, and I'm going to just dive right into it. Mr. Harvey, I believe you're here for public comment. Is that you? Is Ricky Harvey?
Hi, yeah, I'm actually here, but I was really just listening in. I didn't.
Okay, so not
but
here
as long as, but I'll take 10 seconds and say what a wonderful job you all have done this afternoon, and to thank you very much for holding this hearing. It's been very educating, fascinating, and all of your guests were great. So thank you.
Thank you so much. And so I guess we'll just wait. Not sure how long we typically give for this, but because of the Excuse me, I got Gideon's with me. I'm babysitting my pup. Because we don't normally have folks in chamber, but this is a little different. I'm going to give folks about 10 minutes. So I figure at 4:55 we can call it. So we'll just wait another 10 minutes. I'll take this moment just to let folks know some public comment was submitted through email. I'll make sure that that gets to all the counselors at the conclusion of this. So we do have some public comment that came in through email, and I'll make sure it gets to you.
Hey, I think you unmuted me, but I think you may be muted now, Ricardo.
There you go. Yeah.
There you go.
Yeah.
Just a question. Well done, as Ricky said. How did we get the link for the public testimony out? Did we publicize that? I'm just thinking for future hearings that we'll likely have to do.
Yeah, it's a good question. Shane Pack was doing a lot of the things on that. I think on my Twitter, we streamed the link to watch it. That's a good question. And maybe Kerry or Shane can let us know how that got out. I know it got sent out, but clearly we could probably do a better job of it. Maybe at the beginning of hearings, we make it more clear, what that'll be. But yeah, right now, I know Shane emailed it out, and I think we posted it, but that's about the extent of it.
Yeah.
It might make sense if we're doing these hearings on a number of different topics for the foreseeable future, maybe the Boston City Council Twitter. We can use that to say public comment here, public comment there, and then all the councilors can kind of share that out to their networks.
Yeah, I think that's a great idea, and great job, Central staff. This wasn't easy, but all of you did a fantastic job, so thanks, Central staff.
Definitely doesn't look like the first time. So thank you, Central staff, for doing what you've done. With that, we've hit 4:55. I'm going to go ahead and adjourn, and we'll pick a new date in the future to reconvene and speak to folks that weren't able to attend today, because they've been essentially dealing with an emerging situation as we go forward. Obviously, things are going to be changing as we head into the future. Things are always going to be adjusting, and so I appreciate the work they're all doing, and I appreciate everybody here for their cooperation and for their help in putting this together. So thank you, everybody. And with that, this meeting is adjourned.